All right. Good afternoon, everyone. Thank y'all so much for being here and for joining us for the Ron Brown Healthcare Summit. My name is Ray Pryor. I'm a 2015 Ron Brown Scholar and the host of our organization's podcast, The Value of One, The Power of All. And I'm super excited to share with you a bunch of amazing friends and colleagues and fellow alumni that we'll be featuring later on today. We'll have many of our thousands of alumni here in attendance, so thank you for all of you for being here, and special thank you to alumni and our board members who helped make this event possible. And then we also have some new friends joining us too. And then even throughout the event, if you find that there are folks that you may not have thought of who are very interested in healthcare who should be in attendance, feel free to share with them the link and have them join us. For the sake of those folks who might be new friends of Ron Brown, I'm going to take some time to share a little bit about the organization and then kick it over to our first keynote speaker and guest here shortly. But the man himself, Ronald Brown, was the U.S. Secretary of Commerce, and prior to that was the chair of the Democratic National Committee. And he was the first African American to hold both of those positions. He also served 4 years in the U.S. Army. He was a prominent lawyer in D.C. and a very active community member and citizen. And in 1996, at the age of 54, he, along with 34 others, passed away in a tragic plane crash in Europe. Later that same year, Ron's close friend, Anthony Pallaro, sought to perpetuate Secretary Brown's legacy of achievement and global leadership and established a scholarship program in his name. And for 30 years, this organization has invested tens of millions of dollars into over 10,000 of the next generation of African American leaders. Ron Brown Scholars boast a 99% college graduation rate. Their top schools, including the Ivy League, Stanford, MIT, and Duke. And from the data that we have on the past 5 classes, come from households that make on average $41,000 a year. Ron Brown Scholars and captains, despite the humble beginnings that they have always been leading from the front in every domain, from law and politics to technology and artificial intelligence that we showcased last year through our AI summit, to finance and entrepreneurship. And no surprise, they're also on the frontier of medicine and healthcare. And the purpose of today is to put our leaders on display to help inspire the next generation of healthcare leaders for tomorrow. The first half of our time this afternoon, we're going to spend hearing directly from clinicians, people who practice medicine. And then the back half, we're going to shift to folks who are health system leaders, administrators, researchers, former public health officials, and policy leaders focused on healthcare more broadly. And throughout the event, we're also going to be highlighting a few of other leaders who don't have the entire stage to share all about their work, but just want to show a spotlight on a few of our alumni who are doing some great things across the country and even in the world in healthcare as well. So thank you so much for joining us. This is going to be an impactful moment for anybody who's interested in healthcare, certainly undergraduate students, certainly students who are in graduate school, postdocs, all of the different folks who are earlier in their career trying to figure out where they can really make an impact in the healthcare system. This event is for them. So right before I hand it over to Amya Wallace to interview our keynote speaker, I wanted to take a second to talk about a very special scholar who's doing some great work in healthcare in his hometown of Houston. Rahsaan King is a 2013 Ron Brown Scholar. He's born and raised in Houston, Texas, went to Harvard with the support of the Ron Brown Scholar Program. And through some work that he is doing with his parents' church, is taking an old abandoned building that was declared condemned by the government as a result of Hurricane Harvey. And he has completely renovated it into a K-12 school, building affordable housing on the complex that it's on. But most importantly, he is bringing a clinic to one of the poorest neighborhoods in Houston, also happens to be the place where he grew up. That organization is called the Settegast Revitalization Initiative. Highly encourage you to search it and research it and keep up with his progress. Among the many things that make Rahsaan great is that he is a great gatherer of people and has assembled an amazing team. And among the very first people who have been a part of helping him kick this organization off the ground have been a lot of Ron Brown Scholars in his class. Ali has been involved. Leslie has been involved in very senior leadership positions as well. And they're continuing to grow and expand their impact in Houston. And so if you're ever in Houston or know folks in the Houston area who are committed to increasing equity and access for healthcare, please make sure that you keep Rahsaan King in mind, and super excited to continue to see as they develop what in its finished complete state will be a multi-million-dollar complex in a part of Houston that is in desperate need of healthcare services. So Rahsaan is one of many alumni that we'll be excited to highlight throughout the event today. But now I'm going to pass it over to kick off our keynote. First to Amya Wallace to introduce herself, and then she'll introduce Dr. Britt, who will be kicking off our session today.
Thank you, Ray. Hello, everyone. My name is Amya Wallace. I am a 2024 Ron Brown Scholar and a pre-med student at the University of Miami studying biology and health science. As someone aspiring to a career in medicine, it's my pleasure to introduce our keynote guest speaker, Dr. L.D. Britt. He's one of those people whose accomplishments could take up the entire session, so I'll do my best to keep this brief, but I encourage all of you to read more about him yourself. He's a proud Eastern Virginia native. He graduated with distinction from the University of Virginia and was named on the Dean's List every semester. He earned his MD from Harvard Medical School and his MPH from Harvard School of Public Health. He is currently the Henry Ford Professor of Surgery and Edward J. Brickhouse Chair in Surgery at Eastern Virginia Medical School. Dr. Britt is one of the most accomplished surgeons and professors in the medical profession. He is the author of more than 220 peer-reviewed publications, more than 50 book chapters and non-peer-reviewed articles, and 3 books, including a recent edition of the highly touted Acute Care Surgery. He serves on numerous editorial boards, chaired multiple medical associations, and is a reviewer for the New England Journal of Medicine. He has been honored with the nation's highest teaching awards in medicine, conducted 200 visiting professorships at numerous institutions, been recognized by multiple presidents of the United States, as well as the Honorable Regina Benjamin, MD, the 18th U.S. Surgeon General. He was also honored by the Ron Brown Scholar Program at the 2012 American Journey Awards. He has a statue, terrace, and scholarship for pre-med students named in his honor at EVMS. And last, but certainly not least, he has also served on the Board of Trustees for the Ron Brown Scholar Program for many years. Dr. Britt, thank you for joining us.
Well, Ms. Wallace, thank you very much. I want to thank you for this. My life is based on 2 maxims and 2 caveats. Maxim 1, excellent performance transcends any artificial barriers created by mankind. Excellence of performance is not an option, it's mandatory. That's axiom number 1 for me that I live by. The maxim number 2, which is a quote by Martin Luther King, our lives, your life, Ms. Wallace and others, our life begins to end the very day we walk away from things that matter. Now, my caveats that I live by is no matter how smart you are, and I know there's some smart people on this, there will be times when you will fail. And the other caveat is that more people fail due to lack of purpose than lack of talent. So that's my framework. People say, how did you do all of this? Those are the things that I adhere to. I don't deviate from. When I came back to Hampton Roads, and a lot of people, I left all the places you met, Harvard and the University of Illinois and all of that. My colleagues said, don't go back because you're not going to be successful. Well, number one, it depends on how you define success. I like to say be of value versus using the word successful. But I said, I'm going to go back home because they need my support. And so what I did, as soon as I came back, I did what Hernan Cortez did. Hernan Cortez, and I'm sure you know, he was a conquistador. And he landed on what he felt was a new world. And it wasn't a new world. It was Mexico. But what he did was going up against the Aztec army, which 60,000 strong. They had never lost a battle. They never lost a battle. He only had 600 men. He had 16 boats and 11 horses. So as soon as he landed to go up against the Aztec army, the first thing he said, the greatest military strategy that I think, he told his men to go back and burn the boats, which meant that either we're going to win or we're going to perish. And he won. So when I came back, I burned the boats. And I want the people on this line, even if you don't listen to me, Google burn the boats, because that will motivate you. Sometime in life, you have to burn the boats. There's no backup plan. There's no safety net. You just have to obviously just fortify yourself and get it done. So those are the things that I have lived by. And what I grimace a little bit about, This was when people said that he was the first and first. Well, I was the first because they didn't allow my forefathers, my previous colleagues, to have that opportunity. There was so much discrimination. Yes, I'm the first Black and first Black. I said, no. I'm the first because you didn't allow some of my forefathers and foremothers to do this. And so I always push back because what I said, I didn't go through a lot of the things that my forefathers went through, with discrimination and all of that. But I said, you know what I'm going to do? If you hand me the baton, I'm not going to drop it. And so they handed me the baton, and I didn't drop it. So that's the thumbnail sketch of my life. Yes, I have done a lot. Probably too much. I don't remember all the things I've done, all the honors. But I don't care about the honors. My greatest reward, my greatest award or reward is being able to train somebody who can go out and take care of patients. So I'm the most happy when I've trained somebody for 5 years, 7 years, 9 years, and they go out and they do well. All these other awards are transient. I appreciate it. I acknowledge it. Don't get me wrong. But that's not why I'm here. I'm here, as I mentioned before, to be of value. You know, Mother Teresa, a reporter was talking to her. And the reporter asked Mother Teresa, you know, you have to be very pleased. You're so successful. She stopped the reporter and said, well, God did not put me here to be successful. God put me here to be of value. And I feel the same way.
Yeah, I have a couple questions for you, but first off, I just wanted to say thank you for sharing that. I feel like those principles really show up throughout your career. But I have questions about medicine and then also the future of healthcare. But before we get into that, I did want to take a step back and start with just your story growing up. I know you've talked about it before, but you did grow up in the segregated South. So I was just wondering if you could
I
share.
grew up in the Jim Crow South. See,
Right,
the American bald eagle did not fly over the Jim Crow South. I want
right.
y'all to hear that. The American bald eagle did not fly over the Jim Crow South. I didn't know integration until I went to UVA. I finished at segregated high school. And then I went from obviously that in 1968 to the University of Virginia. That's when I was introduced to integration. And what did I see? Confederate flag. What did I hear? Dixie and all of that. But I did not let that hold me back. But keep going. I don't know.
I was just asking if you could just share, I guess, what was life like during that time, and how do you feel like those early experiences shaped who you are today?
I can tell you why. When I went to the University of Virginia, I knew I didn't have a backup plan. I didn't have a safety net. I don't think I could go back to mommy, daddy, and all of that. I knew that I had to do well. And so when I got there, I realized that number one, a lot of people don't realize University of Virginia back then did not accept women. It was all male school. My entertainment was pretty much studying. When I went to the University of Virginia, there were only 12 African Americans total for the whole university, 12 total. And what we did, we decided to just use our downtime to study. And that fortified me. When I went there, I had probably the worst midterm score because a lot of these folks came from private schools and prep schools and all of that. But I realized something. They didn't have that sort of fortitude to study. They did a lot of, don't get me wrong, they were good students, don't get me wrong. But they like to go on road trips, weekends they called it. And I said, you know what? I think I can outstudy them. By the end of the semester, I had the highest average. And when I finished, I was the only one from the University of Virginia to get into Harvard Medical School. So I've dedicated my life to being excellent. I delayed some things. I didn't get married until the day before my 50th birthday. But was that the right thing to do? But that was my strategy. I didn't think I could multitask that well. But I had a focus. I wanted to bring back the best expertise to my home area. Now I'll get to why did I return home? When I was a young boy, I remember that we had to pack a lunch and a dinner to see a doctor in my community because it was segregated, only 2 or 3 doctors for the whole Black community. And I realized something was wrong here. We had to sit in the office for 8 hours to see somebody for just 2 minutes. I knew about healthcare disparities then. And I said, what I'm going to do, I'm going to bring back the best expertise. I didn't train in Virginia. I did my undergrad. I wanted to get all my training everywhere else. Harvard, University of Illinois, WashU, and then bring all that back to Hampton Roads, and that's what I did. And when I got back to Hampton Roads, I negotiated with Eastern Virginia Medical School. I've only had one job, Ms. Wallace, only one job since 1986. And that job was at Eastern Virginia Medical School, because they made a commitment to me. When I got back, I said, look, I'll come here and I'll be committed to you, but I want you to fund an office for me for 1 day a week so I can see patients in my community back home in Suffolk, pro bono. And I made house visits. I did that for 25 years. And I say true, I grew along with the young medical school. My colleagues said, look, if you go back, you're not going to be successful, you're not going to be a leader in American surgery. I said, I'm going back because it's the right thing to do. And sure enough, those same folks that told me not to go back home, I'm helping them out. So when I got back to Hampton Roads, EVMS, they couldn't even spell EVMS. They couldn't even spell LD. But I knew I did not need a portal to be a value. I knew I didn't need a portal to be a leader. I didn't need a Harvard background, Yale background, a Stanford portal. I would do this on my own platform. I was a portal. I was a platform. And I don't apologize for all the things that I've done as far as the sacrifices and the studying and all that, because I meant what I said. People, I want my colleagues I want you and my colleagues out there in cyberspace to realize that the curtain's going to go up on you at least once, if not twice, in your career. And when the curtain goes up on you, I don't want them to see an empress on this stage with no clothes on. And that was a driving force for me. I wanted to be prepared when the curtain came up on me. They saw somebody with excellence. And then as a result, they wanted me to lead this organization, lead that organization. I got all these awards, but I didn't do it for that reason. But I'm telling people, at some point, the curtains will go up on you. I don't want them to see you on the stage with no clothes on. And I define clothes as excellence. So if you don't take away anything else I've said, I want you to take away that.
I'm like right.
And let me say this, people talk about the segregated South. My best teachers came from the segregated schools. My best teachers, they weren't at Harvard. They weren't at WashU. My best teachers were the ones in the segregated school, because they were committed to you. They knew you did not have a safety net. And they were almost like parents. They made sure you did the work. They made sure you followed through. I had my best lessons at those schools. And remember, I finished in 1968. I finished the year that Martin Luther King was assassinated. So I remember coming home one day from a segregated theater. I was walking home, and everything was silent. There was nothing. So by the time I got home, I realized that Martin Luther King had been assassinated. So that motivated me. So when I went to the University of Virginia, 2 months later, the first thing I did when I walked into my room, my roommate wasn't there yet. I was brand new. I hung up a portrait of Martin Luther King to motivate me. And then I went out to get some things. And when I got back, I realized there was some sort of commotion, because my roommate came in, and as soon as his parents saw the portrait there, the parents said, we can't keep our son here. But to his credit, my roommate said, no, I want to be his roommate. And he was the best roommate I've ever had. So that's the background. Nothing is embellished, but I really appreciate my background. I don't apologize for it. It wasn't right, but they made the best out of a segregated system. We had used books and all of that, didn't have the most resources, but we had the commitment. And I wouldn't trade that for anything. See, now you have me unplugged today. You have me unplugged today.
I think it's very clear that your background has shaped your leadership and your legacy. And I think that through the work that you do, we can definitely see the values that you hold. But as someone, like I said, I am pre-med, so I'll be applying to medical school very soon. I was
I
curious.
certainly hope you apply, but make sure you apply to EBMS and I'll support you.
Okay, I'll make
Or
sure.
you apply to Harvard. I can make a phone call. So at some point offline, let me be part of the process to help you get into medical school.
Okay, no problem. I was curious if you could share with us, I guess, what your path to medicine was like, what made you interested in medicine in the first place. I know you ended up going back to your community and helping out there, but was there something, I guess, in your life that made you interested in pursuing medicine? And then, I guess, further on in that, you kind of decided to pursue surgery, specifically trauma surgery, as your specialty.
I'm so
What led
glad you
to that
asked.
decision?
I'm so glad you asked that question, Ms. Wallace. I can tell you exactly. I was a football player. I was captain of the football team. I had a football injury, open wound. And the doctor who delivered me said, look, he was a family medicine doctor. I had to wait hours to see him. He said, I want my son to see you. His son was a surgeon. I didn't know his son. So his son came in. He was tall. He was handsome. He was confident. That person was Dr. O.W. Hoffler. Dr. O.W. Hoffler was the last resident trained by Charles Drew. So when he came in, I turned to my mother and said, I want to be like him. So he started me on the path. I knew I wanted to be a doctor, but he made me commit to being a surgeon. I wanted to be like him. He was on road, and I got to know him. But he was the last resident trained by Charles Drew. And he could have been one of these first. But it was segregated hospitals and all that. But he came in and he was excellent. So that's how I got into medicine. That's certainly how I got into surgery. And you can Google, but I hope everybody knows Charles Drew. He was the last resident of Charles Drew. And he's the one that motivated me.
That's amazing. I know for me, I've been, trying to like shadow different like doctors, trying to figure out what specialty is, I guess, speaks to me the most. But I know obviously once you get into medical school, you have all your rotations. So I just thought it was interesting to figure out
Yeah, but
what really
give
made you
yourself
want
time.
to do
Be
surgery.
exposed to everything. Be exposed to everything. Do your rotations. Don't
Right,
try to make a decision now that you want to be a plastic surgeon or you want to be a dermatologist. Just look and enjoy all the experiences.
right.
And something will tell you what you want to do. I knew I wanted to be a surgeon after I met him. And I was committed to surgery because surgery almost it's like a sport. You have a locker room, you have an outfit and all of that. And it's very high stakes. I wanted something high stakes and something that's not delayed gratification. In internal medicine, these are chronic problems. I wanted to be able to intervene and make sure the patient gets better. That's who I am. I'm not saying there's nothing wrong with being an internist and all that, but that was not for me. But you'll be able to find, expose yourself to the rotations, and something will tell you, what is it? Amya? Is that your
Yeah.
first name?
Yes.
This is what you need to do. Something will speak to you. Maybe being a pediatrician or a psychiatrist, but something will tell you. So don't try to fit it now. Let it happen naturally.
Right. And I know we talked a bit about all of your amazing accomplishments. Is there anything else still on your list that you hope to achieve or work toward?
Yeah, I do. It is something I'm working on. I'm working on changing the paradigm of training surgeons. Right now, we're accredited by the ACGME, Accreditation Council for Graduate Medical Education. It's called residency review committees and all of that. And they are giving us guidelines, which I think will not help you train a good surgeon. You heard about an 8-hour work week, and then they're talking about a 6-hour work week. You cannot train a good surgeon, an excellent surgeon, with a 60-hour work week. You can't train a good surgeon and you tell that surgeon, well, you have to have supervision every moment by your attending. At some point, you have to have some autonomy that strengthens you. And so what I'm doing, one of the things, it's a tough challenge. I'm trying to say we need to have a different process of accrediting programs. In fact, if you look at the Royal College of Surgeons, all the Royal Colleges in the UK, United Kingdom, England, Edinburgh, Ireland, Glasgow, they do their own accrediting. They don't have some other organization telling you how to train surgeons. They train their own surgeons, they accredited training programs. I think we need to do the same because it's hurting patient care because we end up turning out a product that's not a good product. They end up doing fellowships because they're nervous about going out in practice. We need a different system. So I'm on the bandwagon now. I'm a minority. I have a minority opinion, but I'm getting some traction, and people realize we need to change this. So that's what I'm doing now. And plus, I mentor. I mean, one of the things I do, in addition to being a surgeon and seeing patients and all the things you highlighted, I mentor people. I mentor a lot of folks.
Is there anybody that you've mentored that you think, because I know mentorship is kind of like a two-way street. You mentor them and sometimes they can, I guess, help or I guess teach you some things. Is there anything that you learned from one of your mentees that you feel like you still carry with you?
If you look at the leaders, young leaders in American surgery, I mentored all of them. The current chairman at Howard University, the first woman, the first Black woman, first woman and first Black to be the executive director and the CEO of the world's largest organization for surgeons, Dr. Patricia Turner. I mentored her. Dr. Pearson Butler, who's a professor at Yale, I can go down to hundreds of people I have mentored, and they have done well. I'm strict. They realize I give them tough love. The things I take, these are the things you need to do. So everybody's looking for shortcuts. There are no shortcuts. You have to put in the time. You have to make sure you follow up on things. Be punctual and complete your task. And don't get blinded by the glow of fame. Let me say that again. Don't get blinded because people are going to say, oh, you're a doctor and you have this and that. Don't get blinded by that because that will derail you. And I tell people when they get disoriented and all that, and they get depressed, or they burn out, I say, I tell you what you want to do. I want you to go back and fall in love with taking care of patients. Always focus on taking care of patients. If you have that sort of love relationship, you'll never get bored. And you might be depressed a little bit, but at some point you're going to still be focused on taking care of patients.
So you've definitely mentored a lot of leaders in medicine. Is there something that gives you hope for the future of medicine?
Well, number one, I think the future of medicine is good, but in this country, we're not getting our money's worth. We're not getting our return on investment. The healthcare system is the worst of the 6 industrialized countries, okay? Our healthcare system is ranked number 68. Yes, it's great for a certain portion of the population, but if you look at N equals the population, we don't have a good healthcare system. We have this unsafe. We have 40,000 deaths, Ms. Wallace, based on errors that we make in healthcare. 400,000 deaths, 400,000 deaths based on mistakes we make. Taking out the wrong leg, operating on the wrong patient, all those sort of things. And our disparities. We have 42,000 people die every year because they don't have insurance. So, we're the greatest nation of all time. You compare us to the Roman Empire, we're the greatest nation of all time. There's no reason for a great nation not to be able to have health care for their citizens. We have a tendency to become tolerant. We're tolerant of, who has money, who has possessions and all that. We can't afford to be tolerant of who has clean water and who does not have clean water, who has protection and security, who does not, who has education. And we cannot be tolerant of people who have health care and those who don't. We just cannot be tolerant of that. But I'm glad you asked that question.
And I feel like all of that can definitely feel a little discouraging. But do you feel like there was a moment in your career when you seriously questioned continuing? And what was it that kept you going?
Never. Taking care of patients. I mean, it's a privilege. It's a privilege to be chosen to take care of patients. It's a privilege for me for patients to say, you can violate my body, you can open me up, you can remove organs and repair organs. And I don't take advantage. I don't take that for granted. It's a privilege. So there's never a time that I get depressed and sorry that I'm doing. No, I'm helping people. And sometimes it's a favorable outcome, but sometimes it's not a favorable outcome. But my job, I may not be the best. My job is to do my best. And that's what I do as a physician. You know, medicine, we're committed, it's a special profession. And I get mad when people try to compare us to a business. Medicine was never meant to be a business. For those on the phone who have business majors and all that, are pursuing MBAs, the business a mantra is this: there is no margin profit. There is no mission without a margin. So, okay, that's the mantra is there is no mission without a margin. Well, you can't apply that to medicine. You can't say, I want to make a profit off of taking care of the sick. You look at United Health, when a young man was assassinated 2 years ago, he was the CEO of United Health. They had a 24% profit margin. And people are outraged. You can't, that's not our profession. Our profession is not a business, it's not an industry. And it should not be profit driven. Yes, you have to be financially sound, you have fiduciary responsibility, all of that, but you need to focus on patients, not necessarily, we're not going to see patients that we can't make money. Oh, you have me unplugged today.
I guess, kind of like everything that you've mentioned, it can be a little bit difficult to hold on to your values in a system that makes it difficult. So I guess my question is more so, how do you hold on to your values when the system around you, the medical system in general, makes it, I guess, hard to.
It's not hard. You take an oath, Ms. Wallace, you take an oath, Hippocratic oath. And Hippocratic oath, it doesn't say anything about you having weekends off. It doesn't say anything about you having to go to Cancun for a vacation. We have a Hippocratic oath that we adhere to, doing what's best for the patient. Do not harm the patients. Do not do anything that will distract from the specialty. There are certain things. So those are the tenets that we follow. And when you go off the rail, or you cross that double yellow line, then you violated the oath.
Is there a specific moment that you've shared with a patient that you feel like has stayed with you throughout your career?
Yeah. There was a patient, elderly patient, that wanted everything done. But I knew, and he knew, and the family knew that there was no way he was going to get out of his disease. He was in a terminal state. And I had a good discussion with him, saying this to not necessarily that, is a death panel, but you need to be able to, we need to make him comfortable. There's not much more we can do. And he accepted that. And the reason I'm bringing that up, because in our country, for Uncle Leroy, who has all organs failing, 98 years old, all organs failing, and we're doing everything, having the ICU, have to using all the drugs and all that, when we know there's no chance for him to recover. There's no chance for him to be conscious. There's no chance for those organs to get repaired, but we still waste resources doing that. Now, I'm not talking about euthanasia, but we need to realize there's a finite number of resources that we have. And we need to have that discussion with the public. Our public is different. You won't find Uncle Leroy in England. You won't find Uncle Leroy in Japan or Switzerland. We waste too many of our resources, ordering unnecessary tests, unnecessary labs, all those things. We spend $4.5 trillion a year in healthcare expenditures. There's no other trillion-dollar industry in the country that's legal, but healthcare. And the more money it makes it worse. More money will not solve this problem. In fact, I've said before, we need a Steve Jobs type person to come into our healthcare system to totally overhaul it. You know, Steve Jobs, what he did, he blended education, commerce, media for one handheld that you push a button that totally changed the way we live. I bet you right now you have a handheld near you somewhere. You have an iPhone or something near you. We need a person to do that in healthcare, to make it more efficient, where we're not making mistakes, that we communicate, we can reach out into remote communities. But that person is not going to be somebody who's my stature, my age. It's going to be somebody who's young. Just like Steve Jobs was young. In fact, they said the vitalizing work of the world is done from people who are from age from 25 to 40. If you look at the vitalizing work of the world is done there. There might be some exceptions, but not many. And Steve Jobs didn't even finish our college. I'm saying somebody out there in this audience probably can help make this a better system, an overhaul of the healthcare system.
The last question that I personally wanted to ask you is, what advice do you have for the next generation of Ron Brown scholars and captains who are looking to make an impact in healthcare?
I'm glad you said that. I want you to use all the vehicles you have that I didn't have. You have online training. You have all these things that the adjuncts that you don't have to go to the libraries and go through books. You can just Google it. Use that to make yourself strong. Build your foundation. Don't worry about all the other things that, going into committees and doing activities. Focus on building your foundation first. And once you do that, once you have a strong foundation, I don't care what environment you're in, they can't topple you. So focus on building that foundation. And I'm impressed with your time period, because you have all these adjuncts that can help you. I had to go to libraries and look up stuff. You got to be kidding. You can Google stuff. You have all that at your fingertips, and people are still not using it. They're wasting their time on TikTok and Instagram and not using those vehicles to expand your fund of knowledge. Because at the end of the day, weapon, Ms. Wallace, your weapon to go against discrimination and slights and biases will be, your weapon is excellence. Not many people can go toe-to-toe with that.
Thank you. And I would love to use the last couple of minutes that we have together to ask you a couple questions from the audience. So if anybody has any questions that you would like Dr. Britt to answer, you can feel free to write them and I will ask them.
And I'm unplugged, so you can ask me anything. You can ask me how much money I make. I'll leave it up to you. I see the audience is shy, but let's realize I would do this if they didn't pay me a dime. Let me say it again. I would do this if they didn't pay me a dime. It's not the money part for me. It's being able to help and be of value. Remember what I said? I rarely use success, because that's transient. Anything can happen. You can lose your money, you can lose your home, but when you're of value, it's hard to change that. So focus on being of value and not being successful, because there are different parameters and definitions of success. And please don't be blinded by the glow of fame.
We did have one question that came in. They asked, how can we connect with you for mentorship?
I'm so glad you asked. I'm going to give you my cell number. I'll write it down, 757-615-7199. The cell number, personal number, line right to me. My email is all low caps, Britt LD at ODU, which is Old Dominion University, .edu. So Britt LD at ODU.edu, which is for education. And then if you want to get me through my assistant, my executive assistant, Mr. Loach, her number is 7. I mentor people, either I do it online, I usually have a Zoom every few weeks with somebody who wants some mentoring and all that. And I do it without any agenda. All I want you to do, remember what I said, you don't have to be the best. All I want from you is for you to do your best.
And then we have another question that came in. They said that becoming a surgeon is famously difficult, as you've outlined. And what are your thoughts on unionizing efforts of surgical trainees?
Well, I think, okay, to be a surgeon, you really have to go through training. You can't, there's no shortcuts. You have to obviously first you have to do well in medical school and get into a good surgical program. And then oftentimes people do a fellowship. And then obviously, and then you have to do all the board certifications. So it is a long journey, but do it step by step. Do it in a modular way. Don't think about it at the end point. Let's do it step by step. And I'll tell you the strategic steps if you call me. Yes, it's tough. Not everyone, the surgeon's not for everyone. But for me, it's the most gratifying profession. The stakes are high. If you don't like high stakes and fast pace, go into something else. Be a psychiatrist. That way you can sit to the side and you can have somebody laying on the couch. That's not surgery.
Now that it's 1:45, I just wanted to thank you so much, Dr. Britt, for being here today. We truly appreciate your time and your willingness to share your story and your wisdom with us. I know I definitely really enjoyed interviewing you.
Okay, and I've enjoyed it too, Ms. Wallace. Thank you so much.
Now I'll pass it over to Louis Gripper to lead our next session.
Okay. Thank you, Ms. Wallace. Hi, everyone. My name is Louis Gripper Jr. I am a 2022 Ron Brown Scholar studying psychology on the pre-physician assistant track at Emory University. And it's my incredible pleasure to introduce our next guest, Dr. Amanda Johnson. Amanda is a 2002 Ron Brown Scholar who is the Senior Assistant Vice President of Care Models in the Office of Ambulatory Care and Population Health at NYC Health and Hospitals. She attended Stanford for undergrad and Harvard for medical school and business school and completed her residency at UCSF, becoming the Internal Medicine Chief Resident for Quality Improvement and Patient Safety prior to joining NYC Health and Hospitals. Amanda, thank you for joining us.
Thank you guys so much for having me.
Yes, awesome. Yeah, I guess just to start off this conversation, I was wondering if you could share a bit about your background and your personal journey into medicine that maybe your bio didn't cover. I'm just really curious to know like what drew you to this particular work.
Yeah. So if I was to go back in time and try and identify one moment that drew me to medicine, what I will find is that there have just been so many things along the way that have reaffirmed the decision to enter this wonderful profession. I would say that it's really, your first impressions and your first influences start with your family. So when I think about my childhood, I'm from Milwaukee, Wisconsin. I'm the eldest of 6 daughters in my family. And something that was really apparent to me growing up was just all of the time my mother spent in contact with the healthcare system just for maternal care and postpartum care. And then the well visits when we had kind of all 6 of us growing up and needing to get checkups and vaccinations. And that really shaped my sense of what it meant to use healthcare system and what it meant to be somebody's doctor. I think that as I got older and I started to reflect more on what healthcare was, what it wasn't, where it succeeded, where it failed, and I had more in-depth conversations with my family, I started to understand the value and the promise of healthcare in ways in which I could potentially deliver on that promise to populations that haven't been served as well. I think one story my dad shared with me when I was growing up was about getting his tonsils taken out at the hospital we had in Milwaukee. He was a child, under 10 years old, probably around the age of 7, going in for a routine procedure and waking up and hoping for a glass of water, summoning the nurse for assistance and having the nurse actually throw the water at him, throw the water on him. And so just to understand that from very young ages, the discrimination that people have experienced when trying to seek healthcare runs deep and is something that I want to do my best to help turn around. My dad now, when he talks about his doctor, says he has a good relationship with him. And the way that he characterizes his relationship is that he is a white guy, but he gets it. And on the one hand, I'm really relieved that my dad has found a primary care doctor who seems to understand him and understands the impact that race plays on his health. And at the same time, that qualification just shows us how far we have to come, that it isn't a foregone conclusion that you could step into an exam room and be understood by your physician, regardless of who they were, or that you couldn't have concordance with your physician, so that there are some things that just don't need to be explained to the same extent. When I think about my mom, I think again about kind of her experience with maternal care, with women's health, but also the experience of kind of bouncing on and off of various Medicaid plans, and how that fragmentation of care created missed opportunities that really impacted her stability from a medical standpoint, having to meet a new doctor, do an intake, get restarted on certain medications, get reassessed, and not have the longitudinality, not having that perspective of where this person has been over decades, introduces the potential for error. And in a world where, and I'm sure we'll get to this, like Medicaid continues to be challenged and threatened, I know that many other patients have experienced that same kind of fragmentation and disruption of care and stand to do it again without major reform. So that, the idea that science could be used to help people in these ways and more, I think were things that have drawn me to medicine and continue to draw me to medicine. It wasn't until getting to medical school that I really got to suss out different specialties and what would necessarily make me the most happy, knowing that there's a lot in medicine that would bring me joy. But I eventually landed on primary care just because it is, I think, the most direct way to deliver public health through medicine. It is the way to really be somebody's doctor. You are their first point of contact for all things acute, chronic, and preventive. And being a true generalist means that everything is your business. So you get to talk to them about their sexual health. You get to talk to them about their mental health. And you get to keep learning about things as you mature as a physician, as the field matures around you. It's just a place where there's the expectation that you're going to continue to stay on top of everything. And I think that challenge really speaks to me.
Awesome. Thank you. Yeah, I definitely identify with like what you were talking about earlier about like those kind of like negative experiences that you experience within healthcare, or that is particularly your family experienced. I've had very similar experiences growing up, and I think that that similarly drew me to healthcare. And I think it's very interesting how like having those negative experiences can kind of transform you to like want to see more positive experiences for other people. And I think for me, that's something that I'm always thinking about, as demanding as healthcare as a profession can be. The idea that like you can be the person that stops that cycle, I think is like really important.
Absolutely.
Yeah. Thank you. And I know you were talking a little bit about your like medical path through med school. And I know that like you chose to actually pursue a MD and MBA. So I was just curious, like what motivated that decision in particular? And how do you think having training in both like business and medicine has served you in your role?
Yeah. So I would say that because of the places I saw where healthcare falls short, where medicine falls short, I knew from a kind of early age, and I'll say early being like, high school, college, that, well, I want to be somebody's doctor and I want to see them in the exam room. I want to do patient visits. I want to do direct patient care. It's going to take more than that to transform the system that has been so unjust to so many. And so I was like, okay, what are the things that would prepare me to take on a bigger role, that would give me a seat at the table? And I remember going to a panel when I was maybe a sophomore in college and listening to a physician talk about his experience and how he had a MPH, and that gave him some entree into the room where it happens, but it wasn't complete. That the way that healthcare is delivered, it has a public health mandate, is incredibly regulated, and is placed in a market, means that there's probably a lot of different perspectives. And when I was in medical school, I had the advantage of having access to a couple of combined degree programs. It shortens the amount of time that you spend in training. So you can get an MPH or a master's in public policy or an MBA all in 1 year. And I really had to reflect on, where did I think I was going to make the most difference? What was most aligned with my intrinsic skill set? And also what my theory of change for the world was. And so for me, I'd always really enjoyed running student groups or being the director for a play, like bringing these projects to completion or running an operation. And so I had the sense that I'd probably be best suited in by getting an MBA. I think another thing that was apparent to me, and I think Dr. Britt touched on this as well, is like, I don't necessarily think that the solutions for what's wrong in healthcare are going to come from within healthcare. And so I wanted to get a training that was going to expose me to different industries and how they think about solving their problems. And then kind of on a meta level, one of the things that I found real about going to business school was that it was the most culture shock that I had ever experienced in my life. And this is after doing like study abroad in college. But I'm just in an environment where I think, again, for the first time, I really felt like a minority. And part of that was just because there were so many dimensions on which I felt very different from my classmates. So, there's race and gender, but there's also the socioeconomic difference, the kind of worldview, political spectrum, and part of what you need to learn to do if you're going to be an advocate is you have to figure out what motivates other people, including people who are very different from you and who think very differently from you. Because when you're at that table, they're going to be there too. Like I said, we put healthcare in a market. It's highly regulated. And at its core, it has this public health function, but you're going to have to contend with people who are coming at healthcare's problems from a lot of different perspectives and probably don't have all of the priorities that you have. I see as a physician, my role is to represent the patient as best as I can when I'm seated at the table. And so I need to be able to code switch on another level to be able to bring some of those needs and interests kind of to the top of the conversation. And I felt like business school was a little bit of a finishing opportunity, and the challenge of approaching that hypothetical boardroom in the future.
Awesome, amazing. Very cool. I never really, I'm aware of some people who have pursued MBA, but it's like, I don't know how rare it is and how like often it is, but it seems like it was very helpful for you in terms of like almost getting like, yes, you get like that direct patient care side, being a physician, but also being able to advocate for your patients on the back end, through those more business administrative level decisions.
Definitely.
Yeah.
To your point of like, how does it serve you today? How do you apply it? There are technical things like being able to think through clinic flow, like that is the central operational challenge of a primary care practice, for example. I think about it from a hiring perspective, writing job descriptions, writing interview descriptions, designing an interview experience, choosing technology and how to incorporate technology when you're building a workflow, looking at a budget, being able to understand different forms of reimbursement in healthcare, ranging from kind of general fee for service, we pay you for each widget you produce, to value-based payment arrangements in which we give you a lump sum amount of money, and we hope that you can take care of a certain population, produce certain outcomes, and you get to keep the surplus. And the fun thing about it is that each patient for whom you're responsible might pay you in a different way, might be on a different health plan. So like those are some of the technical challenges where I think an MBA has been helpful. But I would say that the larger advantage of this training and what I took away from a general management education is just so much more about people. At this point, my job is to develop people and to help them maximize their own potential. And so it's the organizational intelligence that I think the training has brought me that I get to apply every single day. And honestly, from the first time that you are in a hospital and you are working in a team, because healthcare is a team-based sport, understanding team dynamics will produce, I think, a more effective learning experience as a med student, I think a more effective work experience as a resident and as a practicing physician, and then a more cohesive patient care experience, because you can't do everything on your own. You need to be able to leverage the skills of a team, and you want the patient to feel like that is a streamlined and cohesive experience.
Yeah. Yeah. I don't know, that just makes me think a lot about my own perceptions of like about healthcare and especially like the business side of healthcare. I think I often have like a more cynical view of it, not always sure whether like that side is like always having the best interest. But I think just hearing like what you were saying, it's like it's intertwined in as much as like, you know, like so you have to consider both. And I think it's better to maybe have your hands in both rather than, you know, if you can, than just one, because you are able to really like help your patients in ways that I think we don't traditionally think about when we think about how we help patients in healthcare.
Yeah. I know you want to get on to the next thing, but I will say, I mean, like, I think it's such a rich topic because there's
Yeah.
the your business skill set doesn't need to be about profit maximization. And I
Mm,
think that there will still be plenty of business problems to pursue if
yeah.
and when we can take healthcare out of the market. Like, I don't think that we've necessarily produced better outcomes by relying on competition as the driver for excellence. I think it's definitely left many, many people behind.
Agreed. Agreed. Well, thank you. I remember when we were talking last week, you had mentioned like COVID and like kind of like being a leader during like the pandemic. So you've kind of experienced pretty like in a pretty enormous disruption in healthcare. And so I was just curious, like looking back on that, like what would you say like were like the most formative lessons you learned while navigating like clinical care and leadership like during something as big as the pandemic?
Yeah. So I think to put those lessons into context, I should talk a little bit about how I got there. So, as you mentioned, I finished residency in 2018 and moved from California out to New York. I work for New York City Health and Hospitals. And so that's the public healthcare delivery system, the municipal healthcare system for New York City. We serve all 5 boroughs. We serve all patients with dignity and respect, irrespective of their ability to pay. And so, you know, any and everyone can come to New York City Health and Hospitals. We serve the entire city. And when I first got there, we changed over our president and CEO. The division of primary care was a very, very small office. And I worked on a bunch of different things. So I looked at quality measures for ambulatory care. I did some telehealth implementations, which we'll fast forward to when we talk about COVID and what we learned post-COVID. Worked a little bit on patients impacted by the criminal legal system, but just a touch in the very beginning. Worked on recruitment and standing up a public access program called NYC Care, which means that people who don't qualify for public forms of insurance or commercial insurance still have a way to get healthcare in our public healthcare delivery system. Did a stint as an interim medical director for the primary care practice where I work. So I see patients at a community health center in Harlem. I walk there from my home. And there was a change in leadership in February of 2020. And so I was like, yeah, I can hold down the fort. What's going to happen? Like, just
Yeah.
keep things running until we can get a permanent medical director in place. And then kind of fast forward to March 2020, you know, you really can't see patients because every other person who walks in through the door is getting whisked away to your isolation room. And you've only got one isolation room. And then you have to clear the waiting room. And like it becomes untenable. And eventually you realize that you have a very different situation on hand. So my first months of dealing with the pandemic, we were still in the surge. And when you're in the surge, the lesson is you want to flatten the curve. You might not be able to really break the chains of transmission just yet, but you want to slow the rate at which people are coming into the health system so that you can take care of the sickest and give people the best chance of survival possible. And what is the role of the outpatient setting in that situation? It's to handle the less acute cases. It's to be able to triage. And I think during that time, you were dealing with a ton of uncertainty. I think every single Friday, we would wait for all of the guidelines to change. We had spent the whole week kind of building up systems and protocols and staff expectations and patient expectations based on what the prevailing public health guidance was at that time. And then, you know, just be ready for it all to be blown up the next week. Test, don't test. This is the PPE. We don't have enough PPE. Like that was just what you were dealing with day to day and then adapting to week to week.
Yeah.
Some of the things that we did during the time that I was in charge of the charge of the health center was like we stood up testing, like COVID testing, which at first was kind of a appointment-based system. So people who met certain criteria could get a car to be, show up at their home, take them to the testing site, and then take them back home. And it was very slow, very kind of low volume, and very limited because we didn't have necessarily the supplies to actually collect the specimen or the platform on which to run tests at scale. But once we got around those hurdles, which was through kind of a really massive local government effort, we were able to stand up kind of mass testing sites, and the ability to bring a team together to run those sites and then tweak the operation every single day was actually a really meaningful experience, not just for me, but for the team. They really felt ownership of it. And I'd say a part of that was being actually able to serve your own community. When we were doing very limited testing, some people know the right words to say that will get them pushed to the front of the queue. You're going to be the most likely to get a test. And if you don't speak English, if you don't have the same level of health literacy, you're not necessarily going to be able to get the same access. And as one of the people who was doing testing, it struck me how far people were coming in Harlem from, and how few people from our own clinic we were actually seeing. But once we were community-based testing, like the line was made up of people who resided in our community. And that just felt like now we're finally delivering on the promise of being a federally qualified health center, a community health center. But during the time, they actually were able to find a permanent medical director. And so about 2.5 months later, it's like, oh, okay, well, what do I do now? This was such a challenging but fulfilling experience. What is next? And we had actually gotten through the surge part of the pandemic. We had been able to flatten the curve, and we were ready to think about suppression and actually how to break those chains of transmission. And that's when New York City started its contact tracing effort. The campaign is actually called Test and Trace because it involved scaling community-based testing, initiating contact tracing, and then the last part was supporting people in isolation and quarantine. And that was the part that I got to lead for all of New York City. And there were just so many of the lessons there were more on the organizational level. So it was my, I think, first introduction to city politics. I won't say politics with a lowercase p, but interfacing with a bunch of city agencies, some of whom I had not heard of before, but really understanding how each of us had a role to play when something this dire happens to our city. It was a time where I learned what it meant to lead like on this other level. And I was so grateful to so many of the people who are seasoned city employees and all of kind of the coaching and instruction that they would do to make sure that, you know, when I got in the room, I was ready to speak and ready to make decisions. And I think that for the first part of somebody's career, they're an individual contributor. You're making yourself known because you're doing a good job with the task that was assigned to you. You can progress to become a supervisor and manager, and you get to lead through different people. But at some point, you need somebody else to actually lead your team, and you need to be the one representing your team in these larger discussions. And so having like a deputy, having a good chief of staff, being prepared to ask for briefings or to say, you know, I need more time to make this decision, or to propose potentially a really controversial or unpopular idea, like being ready to do that without necessarily having to be the expert or the person who is day to day on the ground was kind of this next level of learning. And I think was just such valuable training and an amazing development opportunity. I think one of the things that I will always remember, and I say to people a lot because this is what the mayor said to me when he confirmed that I would be taking on this role, was like, don't give away your power. And I have really taken that to heart. Don't assume that you don't have good ideas. Don't assume that your intuition is off, even if you're in the minority perspective. Don't negotiate against yourself. Like, you're there for a reason, and people are counting on you. People are doubly counting on you, I think, in a time like that when the scale of the problem was so enormous. Some other things that I think I'll always remember from the pandemic experience is just also the power of media, for good and for bad. People hear one thing about ivermectin, hear one thing about vaccines, and it can take on a life of its own. But one of the things that I had to do pretty regularly as a part of this was show up at press conferences. We call them pressers. And sometimes you had notice, and sometimes you didn't. You had a great communications and PR team. And so there's opportunity to kind of work through what it is that you would talk about and the points you wanted to make. And I think over time, you realize that you have so much more control over the narrative than you realize. Like, I would spend a lot of time studying to make sure like I had all the numbers and that I had, the talking points down, as opposed to realizing that At this point, you don't need to know all of the numbers. Like, this is not a quiz. Like, you really need to think about what it is the public needs to walk away with and make sure that you are telling them that, up, down, sideways. And a great test of this would be doing a presser and then looking at the coverage, like the articles that would come out after this. And, when they took the right quote, when they had the right summary points, you're like, okay, this is media at its best. We also have the ability to translate so many of our materials into the 14 languages in which we deliver care at New York City Health and Hospitals. We could do mailers, we could do public service announcements, we did radio, we did television. So it was like another scale of getting the story out there. And even for things that I do now that are, just contained to New York City Health and Hospitals, I'll never forget just the power of messaging and really being able to connect directly to your constituents. And then kind of bringing it back to delivery of healthcare, I think some of the things we'll always remember are the transformation from in-person visits to televisits. Back in the day, televisits were the exception, and now they are, provided that we don't get any federal guidance to the contrary, we continue to use them as a way to deliver care. And it really makes it easier to follow up with patients who have to go to work, have to care for children, have to care for adults. Provides a lot more continuity. And then, burnout is real. So dealing with kind of the exodus from the workforce, because people want to have better work-life balance. People are tired. People are traumatized. You can't deliver healthcare with the same expectations you had before just because the workforce has gone through quite a bit. Patients have different demands than they did before. And so how do you create an environment where people who have invested so much in training and have so much to offer feel like they can heal and feel like they can continue to heal others?
Yeah. Wow. Yeah, I think it was a very unexpected time for everyone. And obviously it created a lot of unexpected challenges, but it seems like also like a lot of opportunities, unexpected opportunities to grow as far as like leadership, patient interaction, also like a lot of like policy, like a little bit of governmental work as well. So that's really cool. I know we only have like just a few
I know.
minutes left. That went by so fast. But yeah, I just wanted to open it up to audience questions, see if anyone has any questions. If not, I will ask. Okay, we have one. Okay, it says all large healthcare systems have the challenge of trying to balance multiple key players, each with their own incentives, interests, and objectives that may be at odds with what you're trying to achieve. DEI, for example, is in a constant tug of war, which is currently losing. As a leader within a large, complex health system, can you speak to some of the effective strategies you have used to implement positive change at scale?
So that is an excellent question. So I would say kind of in addition to not losing the message, getting out and having frontline direct communication with the people you're trying to impact. I think that it has been important, especially when you're working in a public hospital and healthcare delivery system, to tap into the mission. And I would say that my portfolio right now is the care of people experiencing homelessness and the care of people impacted by the criminal legal system. And I think by being able to shine a light and say, this is what we care about, and this is the value system that underlies the work we do. We are patient-centered, we are trauma-informed, we believe in multidisciplinary care, we believe in restorative justice, we believe in harm reduction. Like, if you are consistent in your messaging and consistent in your actions, it has enabled us to draw out providers who are oftentimes distributed across 11 hospitals, 30 different community health centers, who might be kind of the only person of that ilk in their location. But they can now raise their hand and say, like, this is something I want to be a part of. How can I join this practice? How can I become a part of this team? And then these teams become kind of reinforcing mechanisms for kind of the same values and the same principles. Like, I don't need to be there delivering the message because other torchbearers exist in that place without me. And usually it requires kind of not just getting the right clinical director or local leader in place, but getting them kind of one other person with whom they can carry the mantle. But I think having a really clear value system, like my team within Health and Hospitals spent quite a bit of effort refining what our kind of mission, vision, values were so that they can be the compass for all of the work that we do. And I think a dynamic in which you are prepared to be called out, like where you're accessible, where you're transparent, also allows you to affect positive change. And sometimes that means, you know, going in person, still making site visits, like still going to the places where people are, and also deferring to them on most issues. Like you are the one who tells me what we need to put on our street medicine vans because you are the one, what we need to pack in the backpack because you're the one doing the work every day. And so realizing that you remain a servant leader, not just for New Yorkers who get care at health and hospitals, but also the people who are doing the good work, allows you to continue to be an instrument of positive change and means that you'll get more opportunities to continue doing that. Like you should never give your power away. You also only have one reputation. And so, you know, protect that at all costs and really reflect and think about if you feel like you're veering off track, like what is getting in the way and how do you ensure that you're continuing to be true to yourself and why you got into medicine.
Awesome. Well, I guess we're at time. This has been great. Thank you, Amanda, so much for speaking with me. You personally gave me a lot to reflect on and think about as like I'm in the process of like transitioning into like a healthcare career. So thank you for that. Yeah, I hope you enjoyed talking as well.
Yeah, it was all too short. Thank you so
Yeah.
much for everything, Lewis, and to those who are on the call today. Please feel free to reach out at any time. Happy to talk more. Would love to hear what people are into and where they're trying to go. And I think that healthcare will be all the better for you all joining the profession.
Thank you. Yeah. Okay, great. At this time, I'll pass it along to Keon Pearson to lead our next session. Thank you.
Hi, everyone. It's really nice to be here. I'm excited to be able to talk today about what I've been doing for the past year in longevity medicine. So I trained in internal medicine at Stanford. Before that, I was at Harvard as an undergraduate, and I didn't know when I was an undergraduate or even in medical school that there was this burgeoning field of what we call longevity medicine that was taking root in places like the Bay Area, in New York, in Miami. And so I wanted to share with you all who are considering careers in medicine or maybe close to careers in medicine, the possibilities that are out there in this growing field, what it is that we're doing, the approach that we're taking, and give you a little insight into other clinics and companies that are also sharing this space. So first, I want to start by kind of setting the ground rules of what is longevity medicine compared to traditional medicine. And there's no single definition, although I do include here a definition from the Healthy Longevity Medical Society, HLMS, that describe longevity medicine as an advanced, personalized preventive medicine powered by deep biomarkers of aging and longevity. It's a fast emerging field. The field encompasses the likewise rapidly growing areas of biogerontology, geroscience, precision, preventative, and functional medicine. So it is clearly in its early stages and still being defined by its practitioners, but I think probably the most helpful dichotomy to think about longevity medicine as opposed to traditional medicine is reactive versus proactive. And I don't mean this in a disparaging way. I mean this in a truly orienting way that describes how traditional medicine approaches the patient. Primarily, traditional medicine takes a reactive approach, which is if symptoms arise, then we treat. And traditional medicine is actually very good at this. I'll talk about this in a future slide, but we've been able to increase life expectancy dramatically using the tools of the medical field. Giants like Dr. L.D. Britt and Amanda speaking before me have been able to leverage this to affect large populations of people. So I don't mean to disparage it at all. What I mean to say is that the longevity medicine approach takes a much more proactive stance, which is treating risk, not just symptoms. So if we know that high blood pressure or high cholesterol or elevated blood glucose lead to worse outcomes, it's best to treat those parameters, those biologic parameters, even before you have evidence of disease. Longevity medicine takes this to a very high level of seriousness. I also want to take a look at the evolution of medicine over time. There's medicine 1.0, 2.0, and 3.0 that a lot of people in the longevity space have described. Medicine 1.0, you could think of it almost as not really medicine. Its goal was to sort of survive immediate threats, and it used the strategy of collective wisdom from, old wives' tales or witch doctors or shamans, lots of things in the herbalist and sort of kind of pseudo-spiritual realm that were meant to alleviate symptoms, alleviate pain to the best extent that they could, but they often were insufficient to get at the root causes of the disease. This was the kind of medicine that was practiced from time immemorial up until about the advent of germ theory, when we started to understand that agents like bacteria and viruses, factors in our own bodies, could contribute to disease pathology. I love this picture of the Oregon Trail game, which I never played, but it's kind of a famous game. You have died of dysentery. So that's kind of my image of what happens in the medicine 1.0 era. Like, people were living to their 30s and 40s if they were lucky, but life was nasty, brutish, and short under this paradigm. Enter Louis Pasteur and germ theory and randomized clinical control trials and epidemiology, large population data sets, and we start to get much more standardized medical care. The goal of medicine 2.0 is to understand the root causes of disease and then develop effective therapies and treatments for those diseases. I think of Johns Hopkins as kind of the pinnacle of medicine 2.0. Very esteemed, very established, very legitimate. And through the efforts of doctors at places like Johns Hopkins, life expectancy in the developed world has more than doubled from the early 1800s to today. In the early 1800s, like I mentioned, the average life expectancy was 41 or 42. Now, in some parts of the world, such as Singapore and Japan, the life expectancy for women approaches 90. Which is really spectacular. And this is to the large credit of medicine 2.0. We have the possibility of going even further. And I think this is where medicine 3.0, or longevity medicine, enters the picture. This is where we're using deep, complex systems analysis enabled by AI, very large data sets, molecular understanding at a very deep level, to prevent disease from even occurring in the first place. Here, instead of leveraging large populations, we're going small. We're going to the individual person for individualized risk assessments to treat risk of dysfunction and disease prior to symptom onset. We know that if you can treat diseases before they begin, the outcome is likely to be much better. So that's what I'm interested in doing, and that's what I've been doing for the past year at the clinic where I work, which is called Human Longevity. There are several longevity clinics that are in existence today. They're sprouting up faster and faster each year. Human Longevity was one of the first clinics in this space that was founded back in 2013 or 14 by the person who discovered or decoded the human genome, J. Craig Venter. He had this brilliant idea that after decoding the human genome, we should actually be able to use genomic insights to predict disease and therefore get in the way of disease from developing. So he founded a clinic in San Diego. That clinic grew large enough that they started another clinic in San Francisco, which is the one that I am the medical director for. And there's also a clinic in Beijing. There are other clinics in the space, such as Fountain Life, which you might have heard of, started by the motivational speaker Tony Robbins and Peter Diamandis. They have clinics all over the East Coast in places like Florida and Texas, I think also in New York. And they're doing a lot of similar things with genetic analysis. And they're also offering actually pretty advanced therapeutics like stem cell therapies, plasma exchange, and peptide therapies. And then Biograph is yet another clinic that exists in this space. It is very similar to Human Longevity, that focuses a lot on functional and physical medicine, things like VO2 max, and grip strength and performance assessment to keep people feeling fit and robust and strong as they age. These clinics are already delivering longevity care, and they have a need for clinicians and physicians, nurse practitioners, nurses. So if you are someone who's interested in working in this space, there are job opportunities available. They offer validated diagnostic tools. Not all these diagnostic tools are FDA approved, which is to say that the FDA hasn't weighed in to say that they should be covered by insurance or should be marketed, but they are backed by significant amounts of data. And I'm going to show you some of those diagnostic tools, as well as some interventions, which I try to steer clear of the interventions in this talk, but there's a lot of stuff going on in this space. So next, I want to move on to some of the diagnostic tools that are being leveraged at these longevity clinics. So one of them is called the Grail Gallery test. And the reason I mention this is even if you're not someone who's interested in going into medicine, even if you're not someone who's going to practice longevity medicine, the Grail Gallery test is truly changing the way that we're doing cancer screening in this country. And it's actually relatively affordable. I say relatively because none of this comes cheap, but this one is available at less than $1,000. And it's a test that uses DNA that's released from tumors in one's body, even before that tumor has metastasized. So you could think of it as a small little collection of cells that has connection to a blood supply. Those cells, as they die off, they release DNA into the bloodstream. And the DNA of cancer cells looks actually very different from the DNA of normal cells. This test was developed to detect that DNA. And moreover, the DNA signature on its methylation pattern, which is an epigenetic modification of the DNA, can tell you where precisely the tumor is originating from. So I'll give you an example. I had a patient, person in his 60s, who was very fit, very active, riding horses, prior high-level executive, who had irregular screening with my company. One of the screening tests came back positive concerning for colon cancer. It wasn't this test, but it was a different test. And so that person went for a confirmatory colonoscopy, where they used a camera to go inside of the colon to look for polyps and tumors. Well, they didn't find any polyps or tumors on the person's colonoscopy. So they thought, oh, well, that test was probably a mistake, maybe a false positive. He went about his life, and then the next year came back for screening. I offered him this test, the Grail Gallery test. And again, now this test was positive for concerning for colon cancer. And initially, the patient was very confused. He had already had the confirmatory test, which said that there was no cancer. But my confidence in this test was actually pretty high because, as you can see from the chart I have on the right, colon and rectal cancer the test is about 82% sensitive for that kind of cancer. So when it came back positive for colon and rectal cancer, I said, listen, my friend, you have to go back to the endoscopist, the GI doctor, and you have to get another colonoscopy. The GI doctor was kind of offended at the suggestion that she had maybe missed a colon cancer on her first colonoscopy. But I talked to her and we eventually prevailed in convincing her to repeat the colonoscopy. Company, Grail, reached out to me before the second colonoscopy, and they told me you should look at the appendix because the signature on this colon cancer resembles that of appendiceal cancer. Appendix is near the colon, but it's not exactly always covered completely by a colonoscopy. So I told the GI doctor, when you go in, take a look at the appendix. Sure enough, on repeat colonoscopy, looking at the appendix, there was a large mass. By that point, the mass had grown so large that she couldn't remove it endoscopically, and the patient had to actually go back for surgery a few weeks later to have it removed. But the point is that this test was picking up something that even the gold standard of care, colonoscopy, had missed. And I think that it's a confirmatory story for me that this test has a large potential to revolutionize the way that we do cancer screening in America. You might notice on the sensitivity chart here that many of the cancers are actually not ones that are typically covered by insurance for screening. Insurance usually covers colonoscopies, lung cancer screening if you're a smoker, prostate cancer screening if you're above a certain age, breast cancer for women. But it doesn't cover more aggressive forms of cancer, like esophageal cancer or pancreatic cancer. Pancreatic cancer tends to present at the very late stages, stage 3 or 4, by which point the survival is less than 5% at 5 years. So if you have a test that's able to detect pancreatic cancer before it metastasizes, this can potentially change the game on cancer survival. Speaking of cancer survival, there are some very prominent cases of individuals who unfortunately were kind of failed by the traditional medical model and died early in their prime, actually, from cancers. In fact, on the topic of pancreatic cancer, Steve Jobs, former CEO of Apple, who was referenced earlier in today's talks, died at age 56 of pancreatic cancer. And he was someone who actually was diagnosed at an early stage, but he believed more in medicine 1.0, herbal medicine, spiritual therapy, and declined treatment initially. By the point that he was eventually convinced to accept traditional medicine, it was actually too late, and he died. The person to the left of him on the screen is Susan Wojcicki. She was the CEO of YouTube and a very powerful figure, very fit and active, was running 5 miles per day. She had hip pain one day, and she thought, oh, I'm an active runner, so maybe it's just an injury from that. So she went and got a standard MRI of her hip. Well, it turned out that she had a form of lung cancer, which is more common in people who are non-smokers. She'd never smoked a day in her life. She, in fact, never would have qualified for the insurance-covered lung cancer screening because she never smoked. But here, she had a lung cancer, and it actually ended up taking her life early at age 56. We believe at Human Longevity and in other longevity clinics that both of these individuals could have lived much longer lives had they undergone whole body MRI earlier when they were pre-symptomatic or asymptomatic. Here's a picture of the MRI machine that I actually use at my clinic. And you can see it's very kind of new agey, space agey, very beautiful. But these scanners can pick up on small lesions before they metastasize. It detects tumors and structural abnormalities, and there's no radiation involved. Now, sometimes, and for some disease entities, the MRI is not the best test. For example, actually, for colon cancer, it's really hard to see on a whole body MRI. So you need to do either CT or the gold standard is, again, colonoscopy. For lung cancer, sometimes it's better to do a CT, but the whole body MRI can pick up some lung cancers as well. So this is a technology that could have been life-saving for these individuals. And there are companies out that are offering whole body MRIs for less than $1,500. So it's not in the realm of, it's not super expensive. It is relatively expensive, but it's not impossible for most people in the middle class to be able to afford an MRI scan once every couple of years. Another imaging modality and screening modality that is being used by a lot of these clinics is the DEXA scan and the in-body scan. So on the left, you can see the in-body scan. That's a scale that actually you step on, and it uses electrical impedance, electrical flow through the body to measure body composition, things like muscle, water, fat, and give you a very clear sense of how likely you are to have frailty, issues with obesity in the center of your body, which can lead to metabolic disease, and areas that you can work on and improve by limb. The DEXA scan on the right looks at bone density and also body composition, and it's very helpful to identify if people need to do more weight-bearing exercise to prevent themselves from having fragility fractures later in life. We know that for a woman in her 70s or 80s, a hip fracture can be lethal because they're usually people who've had a hip fracture are required to be bedbound for some period of time. They are at higher risk for blood clots, and they're at higher risk for deconditioning as they're not able to use the rest of their body, use their muscles to keep strong. So it's important to know your risks, and these scans can actually be done very inexpensively. In-body scanners are often present at gyms, membership gyms, and you can step on them usually as part of your membership. DEXA scanners are available for $50 to $100 in clinics around the country. There are also lab tests that can be done that are cutting edge in terms of their ability to look deeper inside one's body. So there's a company called Genova Diagnostics that my clinic uses a lot, where they measure functional biomarkers, things like inflammation, food sensitivity, one's microbiome. We know that all of the bacteria inside of your gut influence a whole host of metabolic parameters, diabetes risk, obesity risk, cancer risk even. And so if you're able to get a deeper look inside of your microbiome, you can adjust it with dietary changes and even antibiotics to improve your overall performance. True Diagnostic is a company that is popular in the aging space because it uses epigenetic modifications similar to the Grail test to analyze your biological age. It turns out that our DNA is undergoing constant modification at a relatively constant rate. And so if you look at the number of modifications that have been applied to the genome, you can accurately assess how old a person is biologically. Some people have a biological age which far exceeds their chronological age. Say they're age 32, but their biological age says that they're 40. That might be a yellow warning sign that they need to adjust their lifestyle, their diet, their exercise routine, and even medications to reverse some of that epigenetic aging and in that way reduce their risk of mortality. We know that people who have substantially higher biological age have a much higher risk of mortality in the 5 years after taking the test. And then the last test that I'll review here is the whole genome sequencing. This goes full circle back to what I mentioned when I talked about the founding of Human Longevity as a company. The insights that we can glean from the genome are multifold and increasing every year. Of course, your entire body's programming is all included in a single cell in the form of your genome. And so all of your risks for things like cancer and heart disease, dementia, can be predicted from just your genome alone. There are single genes that lead to higher risk for disease. You could think of Angelina Jolie, who did a double mastectomy prophylactically because she had a BRCA2 gene mutation, which conferred an elevated risk of breast and ovarian cancer. There are also polygenic risk scores, where it's not just a single gene like BRCA2, but a whole host of genes, maybe thousands of genes, each of which can marginally contribute to a person's risk of developing a disease. And if you collect all of those genes in a single score, a polygenic risk score, you can say with some certainty, not 100% certainty, but with a reasonable level of concern, if a person has a high polygenic risk, they may want to adjust their lifestyle factors to reduce their risk of developing that disease. For example, if you have a high polygenic risk score for, say, diabetes, that's helpful for you to know. It's probably a good idea in that case for you to avoid processed sugars, exercise regularly, and to have your blood drawn annually to make sure that you aren't developing diabetes. So we in the longevity space are using all of these diagnostic tools, and I went through them kind of quickly, I know, but there'll be time for questions at the end, I hope. We're using these diagnostic tools to deliver insights for people so that they can address their risk before they develop disease. Why does this matter? I think in my case, I was motivated to become a doctor because I saw firsthand the disparities in health outcomes. As an African American in this country, and as Amanda and Dr. Britt both can have attested to, race matters. We can see it in the hard data of life expectancy. African Americans have seen a drop in our life expectancy from 74.8 before the pandemic down to 70.8 years. That's awful, and we're moving in the wrong direction. It's even worse for our Native American brothers and sisters, whose life expectancy is down to 65.2. Now, pretty much all ethnic groups experienced a decline in life expectancy after the pandemic. This is true for even white Americans who saw their life expectancy drop to 76.4 years, Hispanics whose life expectancy dropped to 77.7 years, and for Asian Americans who have the highest life expectancy, theirs dropped from almost 86 years to 83.5 years. But the biggest populations who need our help are the underrepresented minorities, African Americans and Native Americans. For me, this is vital. This is personal. And it's kind of a shame to think about all of the talent, all of the potential that we've lost through early mortality. I've included some pictures of some prominent folks, and you may recognize these folks, and I'm going to give them a moment. I'm going to honor them for a little bit. These are incredible people who didn't live beyond the age of 60, but who, if they had, probably would have contributed so much to our overall culture and certainly to Black culture. The first picture, I don't know if anybody recognizes her. It's Octavia Butler. She was a genius. In fact, she won the MacArthur Genius Grant. She wrote a book back in 1987 and then a sequel book in 1990 that described America in 2025. And it was a book that described an America that was racked by opioid epidemic, by global warming catastrophe. And she wrote in the sequel book about an ethno-nationalist president who uses the slogan, "Make America Great Again," to paper over his economic, scientific, and personal failings in the country. He starts a war with Canada, and he uses a paramilitary force to suppress and kill his own citizens. Suffice it to say that she was a prophet, even back in the early 1990s. But she died at age 59 from a stroke. I like to think that if she had been my patient, we would have kept her alive. Reginald Lewis, down below, he graduated from Harvard Law School. He's the only person admitted to Harvard Law School who didn't actually have to apply to get in. He was so brilliant, they accepted him even before he applied. He went on to found a company that had like $1.8 billion in revenue. It was the only company in America run by a Black man that had $1 billion in revenue. He was committed to fostering African-American artists and scientists. He had plans to build an African-American museum. He would have been incredible as a contributor to the society, but he died at age 50 from a brain tumor, which we would have seen if we had done a whole body MRI on him. To the right of the screen is Barbara Jordan. She was a congresswoman from Texas, brilliant woman, helped to lead the impeachment against Richard Nixon. As you can see here, she was a very forceful person to reckon with and commanded the room wherever she went. She died at age 59 after complications of multiple sclerosis and leukemia. We would have detected the leukemia on our labs. And then the last one I want to mention is Bernard Tyson here in the top right. He was a CEO of Kaiser Permanente, one of the largest health systems in the country, in the world. CEO, had access to the best doctors. He died in his sleep at age 60 from a heart attack. We would have caught his heart disease in no time with our screening at Human Longevity. So it's personal to me because I feel like these are people we could have saved and who could have contributed a lot to society. On the other hand, the billionaire class does have a head start. Unfortunately, they are taking advantage of these clinics. I don't really want to spend time naming these people, but suffice it to say that they are coming into clinics. They are living well into their 90s, active lives, busy schedules. And I can assure you that it's not because of their optimal diets or because of their superior genetics. Warren Buffett is known to eat junk food on a lot of occasions, but he's like 96 or 97 years old and still at the helm of Berkshire Hathaway, or until recently was at the helm of Berkshire Hathaway. So, this kind of service is already out there. It's already working. It's already helping people. But the challenge that remains ahead of us is to democratize it, to expand this technology and this service beyond elites, and to make it affordable and accessible to everyone. And I think that's where you all come into play. So with that, I think I'm right at time. And I'd like to, I guess if there are any questions, I can take them. Otherwise, I'll hand it back to Ray.
Yeah, that was excellent. I just had a quick question for you. I was listening to an interview with the TrueMed CEO that's allowing folks to use HSAs to cover things like Aura rings and other wearable devices, more lifestyle choices that might also help with longevity. But the more broader question I had for you was, what are the biggest levers to that democratization? Is it that payers start allowing these things to be reimbursed? Is there some other mechanism that we would need to unlock in order to see more people be able to afford these kinds of treatments that you're pioneering?
It's a really great question, and I think there's a double-pronged approach. One is with more volume, with more utilization of these services, the price comes down because as more people use the services, the market grows, more suppliers come onto market, and then therefore the price comes down. We're seeing that with companies like Grail, which used to be over $1,000 and now it's $790. The price is coming down as new entrants come into the market. The second prong is more arduous, but probably more likely to lead to great democratization. And that's getting approval from the FDA and other regulatory bodies so that insurance companies can start covering some of these interventions. It's happening. I think Grail is on track to be able to is on track for FDA approval probably this year. We're crossing our fingers that that happens. And once that happens, then they can go for Medicare, Medicaid coverage, and then we're off to the races. So those two approaches are both necessary to democratize.
Yeah, that was excellent. You did an excellent job with that graph talking about how longevity as a tool to close disparities in lifespan and health span for underrepresented communities in particular. You've had a chance to share with me why that matters so much to you. Can you share with the audience as much as you want to or have time to about why disparities in life expectancy matter so much to you and hits home for you and people you care about?
Yeah. I didn't talk much about my personal story here, but I was, I'm raised in a family where the men tend not to live much beyond 65 if they reach 65 at all. Um, and it's a combination of things. Part of that is truly it's difficult to be a Black man in this country, but also it's access, also it's lack of understanding. The medical system doesn't understand my family and my community, and often my community doesn't understand the medical establishment. So there's a disconnect there. And I saw it firsthand growing up in that kind of an environment. And that's what drove me to become a doctor in the first place. I actually saw as my great grandfather who helped raise me, big, strong, 6'4", built an addition onto the back of of our house with his bare hands. And he had a heart attack in his late 50s. And that laid him low and resulted in depression and all of these consequences afterwards. And he eventually died, a kind of a broken man. And I think that the healthcare establishment failed him, to be honest. So I don't accept failure. So when I see that, it's my mission to make it better. And so that's what I've been trying to do.
Well said, Keon. Thank you. This was amazing talk and presentation. Some folks who listen to our podcast got a glimpse of some of the concepts you talked about, but always a treat to get to hear you talk about this and looking forward to seeing where things continue to go with that. I don't know if we have any questions in the audience, just praise from Haile that she also enjoyed the talk as well.
Thanks, Polly. And thanks to you as well, Ray. You've put on an excellent conference here. So really, mad kudos to you.
Yeah, well, thank you. I appreciate you being a part of it and making it great. So with that, I think what we'll do is transition to our break. Before we do so, I just wanted to take a second to highlight another one of our alumni who's doing some great work in healthcare. Tsikata is a 2014 Ron Brown captain. He's a founder and CEO of Volta Health. What they're doing is automating a lot of the back-end processes that college campuses need in order to serve their students well. If you can think about all of the complexity of the healthcare system that we have been exploring today, there's an even new dimension and layer that happens when all of these young folks go into new places where there's a lot more things to grapple with and consider, particularly with them being away from home oftentimes. And he is getting the charge for what the new version of campus and student health needs to look like. And so would highly encourage you to look up Tsikata and Volta. He's got a great podcast where he's interviewing a lot of student health leaders from campuses across the country. And that there are a lot of things that we want to get right, a lot of policy decisions that we can make. And there are also just some matter-of-fact technology solutions that he is building to help make those decisions even easier for leaders to make too. So we're grateful to have Tsikata as a part of our network and one of many healthcare leaders that is doing some great work. So now what we're going to do for the next 8 minutes or so is just take a break. We have been going for quite some time with having some great back-to-back talks, starting with Dr. Britt and then Dr. Johnson and now with Dr. Pearson. And we still have 3 more great conversations to have before we wrap up this afternoon. I'm going to play an episode of our podcast in the background in the meantime. So feel free to stand up, go to the bathroom, stretch, get a bite to eat or snack. And then right at the top of the hour is when we'll plan to start our next talk. So thank y'all so much for being here and looking forward to seeing you here in a little bit. All right, y'all. We are set for our next talk. What I wanted to do briefly was to share a little bit about the gentleman who you just heard from on the podcast episode. Joel is another one of our alumni who is perhaps the most well-known, at least on the internet, in healthcare, and soon to be the most well-known more broadly and in terms of his impact in the healthcare space. He's known as the medical Mythbuster and has created quite a large following on TikTok and Instagram in particular. He also has a mixed live action cartoon show for students to learn more about medicine on YouTube called The Doctor Is In. Hundreds of millions of people have seen his work. He's been invited to speak on every single platform that you can think of, from the White House to the New York Times to NPR to Good Morning America. He's spoken in front of all of the major companies you can think of, a lot of great associations within the healthcare sphere, many, many accolades that he's earned. But among the many things he also does is that he's the host for The Dose, which is a podcast by the Commonwealth Fund as well. And so just wanted to take a second just to brag about him and to thank him again for being on the podcast. This is something that you will probably see on your social media timelines sooner than you will see him as a patient or see him in other capacities. He's grown to prominence a lot earlier in his healthcare career than most other folks do, but still nonetheless is doing amazing work and has built a great foundation that he'll only continue to build on throughout his career. So just wanted to shout out Joel and feel free to find him on TikTok and Instagram and continue to show him love in the comment section of his posts as well. Next, I have the honor of introducing Geraldine. Geraldine is wears many hats, but the capacity that I asked her to come speak with today is as a researcher at Mathematica, which is one of the most prominent think tank and research firms based in the DC area that focuses a lot on public health. She's a 2004 Ron Brown Scholar who went to UVA for undergrad. She went to UNC for her master's, which as a Duke alum, I will forgive you, Geraldine, for choosing Carolina. But no, just joking. And then went to Hopkins for her PhD in health services research. Her research is focused on mixed methods. I think she's been at Mathematica for most of her career, but has a very broad view of not just the future of public health and healthcare in America, sitting within a research think tank that has close relationships with the federal government through all administrations, but also has some interesting insights that she'll share about the future of health services research too. So Geraldine, whenever you're ready, thank you so much for being here and excited to give you the floor to share more about your work.
Sure. Thanks so much for having me. And my loyalty is all to UVA, so it's fine. I stick to my undergrad for loyalty. I'm really excited to be here and to chat with you for just a little while. I'm Geraldine Haile. I'm a 2004 Ron Brown Scholar. And today I really want to share my perspective on the future of health policy and health services research, informed by my work as a researcher primarily in the federal healthcare space. I do want to note that my views in the presentation here are my own and they do not reflect those of my employer. So during this talk, I really want to frame the entire conversation by thinking about where we've been, where we are now, and where we might be headed in health policy and health services research. I'll start with a quick look back at some of the key health policy changes over the past 20 years. But at the same time, I want to integrate how my own research and my career evolved alongside these shifts in policy. From there, I'm going to talk about the current moment in health policy and health services research, using the Make America Healthy Again initiative as a way to ground the conversation and to think about what this could mean for population health. Finally, I'll share some just brief thoughts on where health policy and health services research might be headed and what feels different. In the next few slides, I'll share a bit about my background and my career path. But before I do that, I want to start by talking about the relationship between health policy and health services research, because this is really the intersection that's central to my work as a health researcher. So we think about health policy as the decisions governments, payers, institutions make around how healthcare is organized, paid for, and regulated. Health services research, on the other hand, looks at how care shows up in the real world and what impact it has on people's health and on costs. Health policy questions might include questions like, should Medicare cover a specific service? How drug prices should be regulated, or whether states should expand Medicaid. Health services research helps to answer these questions by examining whether services lead to better outcomes, whether interventions reduce or widen health disparities, and whether the cost of care translates into meaningful improvements in health. Health policy and health services research are inherently connected. You can't make good policy without health services research, and HSR matters most when it's working to inform policy. With this in mind, the cycle of my work as a researcher typically looks something like this. Much of my work sits in the evaluation space, where I'm often asked to assess a new program or a new policy at the federal, state, or local level. In response, I work really closely with a multidisciplinary team of researchers. We use HSR approaches to examine how changes affect care delivery in the real world, including the impact they have on quality of care, on health outcomes, cost, and access. Importantly, this work is designed to be practical and decision-focused. We translate our findings into clear and actionable insights, and we share them with our clients, who are usually policymakers or program leaders. The evidence then helps inform decisions about whether a policy or program should be refined, expanded, or in some cases, whether it should be discontinued altogether. And this way, evaluation becomes part of an ongoing feedback loop, where the evidence directly informs policy rather than serving as an endpoint on its own. So I mentioned that I wanted to frame the conversation in the context of past and current health policy. So I want to start back in 2004. So this is the year that I became a Ron Brown Scholar. As my starting point in public health, back in high school, I started an HIV/AIDS awareness club, and I spent a lot of time in the community. I'm from Miami, Florida, promoting STD education, testing, and awareness. But in the same window of time, there was so much happening in health policy reform and in evidence-driven care on a national stage. So to set the framework of their foundation here, at this point in time, a lot of states were trying individual reforms. This period coincides when Massachusetts implemented healthcare coverage that significantly reduced the uninsurance rate there. And this encouraged other states to really start thinking about how they can address the cost of the issue of cost and the issue of healthcare accessibility. During this time, we also started to see a growth in comparative research, or comparative effectiveness research, as more federal dollars were being directed to compare real-world interventions. And this laid the groundwork for PCORI, the Patient-Centered Outcomes Research Institute, which was founded later in 2010. Policymakers and researchers moved beyond access and utilization and started thinking about measuring quality, safety, and performance. So thinking about pay for performance, public reporting, and quality metrics playing a more crucial role. We also started to see at this time a real growth in electronic health records and data infrastructure, which really reshaped care delivery and enabled large-scale evaluations, or large-scale outcomes and quality research that became parts of evaluations. And lastly, research really started to examine racial, socioeconomic, and geographic disparities. So conversations and policy really started targeting equity and looking at interventions that would target populations that were facing these disparities. So as I watched this unfold, it motivated my decision on what I wanted to study. So I ended up studying Econ, African American Studies, and Global Public Health at UVA. And during this time, I also had a few internships that really contributed to my interest in public health. So for 2 summers, I worked at the Institute of Human Virology, once in Baltimore and once in Nigeria, where I also did a lot of work around HIV education. When I was approaching graduation from UVA, I knew I wanted to study public health. And I feel like I applied to a lot of schools, but I ended up at Chapel Hill, where I studied health policy and management on a research track. I worked with Dr. Peggy Dilworth Anderson, who was and still is a real powerhouse in the field of gerontology. So I spent my 2 years at UNC working for the Center for Aging and Diversity, where I conducted research on the impact of race, ethnicity, and culture in aging and caregiving. My master's thesis looked at racial disparities in psychotropic drug use and expenditures among older adults using some secondary data. So early in my career, my focus was really heavily quantitative. And it was also at Chapel Hill that I published my first real publication with like someone famous. And this publication was with Dr. Dilworth Anderson, where we looked at social justice, health disparities, and culture in the care of the elderly. So moving on to the next period that was really pivotal in policy, but also in my career trajectory. 2010 to 2016, a lot going on in the field of health policy. And one of the biggest things was the Affordable Care Act. So the Affordable Care Act was passed in 2010. And the focus at this point moved from policy design to really implementation and evaluation, with a lot of health services research really beginning to examine Medicaid expansion, insurance marketplaces, access to care, and early impacts on outcomes and disparities. Expanded coverage continued to reveal gaps, which led to research around social determinants of health, health equity, and variation across populations. Medicare and other payers started to expand value-based care and alternative payment models, which really started to drive research around quality measurement, incentives, and provider behavior. I mentioned the creation of PCORI back in 2010, but this continued to play a vital role in this period, where patient-centeredness, stakeholder engagement, and real-world evidence became one of the central parts of health services research. And lastly, a wider EHR adoption and claims data led to more timely and policy-relevant research as well. So during this time, I was in my last year at UNC, and I decided to streamline my potential next steps. So I knew that ACA was huge at this point, and I knew it would open up an exciting space for research and evaluation opportunities. So at this time, I applied to a federal research job, and I also applied to 2 PhD programs. I spent a lot of time looking at schools, programs, people who were doing really interesting health disparities research. And then I would reach out to them and see if they were willing to take on new graduate students. I wanted to make sure they weren't leaving the school they were at or going on sabbatical or anything like that. So ultimately, I did not get the federal research job. And I ended up getting a full ride to Hopkins, the School of Public Health, where I studied health policy, health services research, alongside Thomas Levis. So Thomas Levis was my advisor, and he is a really well-known name in the health disparities field as well. So I spent 4 years at Hopkins working with Dr. Levis at the Center for Health Disparity Solutions, and also working with other folks at Hopkins who also were really deep in the health disparities, health equity, and access to care space. Kept my publications going at Hopkins. So I published quite a bit with Dr. Levis, but I also published with a lot of other folks involved with access to care, quality of care, because that was sort of my little window while I was at Hopkins and right in the time that I graduated. My PhD dissertation focused on assessing medical home transformation among federally qualified health centers. I didn't talk about PCMH much, but around 2007, there was a huge emphasis on patient-centered medical homes as a crucial part of healthcare. And the main components here were comprehensive care, patient-centered care, care coordination, enhanced access to care, and quality and safety. The Affordable Care Act embedded the main components of PCMH into broader delivery and payment reforms. So it was a really big part of education when I was at Hopkins as well. So as a part of my dissertation, I developed and validated a scale to test medical home readiness in health centers, and I used secondary data to analyze relationships between medical home readiness and health center, patient, and community characteristics. One of my favorite parts of this journey was primary data collection. I really enjoyed working on the survey, testing the survey, and having conversations with experts as I developed the survey. So I knew that I would work in primary data collection in some way in my future career, and it's something that I definitely kept thinking about. So by the end of my graduate study road in 2014, I was exhausted. I still feel a little exhausted, but I focused my job search on industry. I looked at research and consulting companies as a good break from academia, but I still really wanted to do real world research that could directly impact people like me and people around me, people in the communities that I'm from. And I ended up at Mathematica. And I started as a survey researcher, and I focus a lot on primary data collection and analysis. So a lot of qualitative work, interviews, long surveys, or surveys across long periods of evaluations and that sort of thing. I will say, like Ray said, this is a really short story because I've been with Mathematica my entire postgraduate career. I've been there 11 years, and I love the work that I'm able to do there. So I'll talk a little bit more about the work I do and projects I've worked on in the upcoming slides. So I want to talk now about this period, 2016 to 2020, and what was happening here. So during this window, there's a lot of debate going on related to Affordable Care Act repeal and replace efforts, Medicaid work requirements, Section 1115 waivers, and regulatory changes. Attention also began to shift to state policy variation and effects on coverage, access, and disparities. ACOs, bundled payments, alternative payment models, all moved from like pilot stage to broader implementation. So health services research really began to focus less on whether these models were working, but more on who they were working for, under what conditions, and at what costs. Lastly, we started to see a growing emphasis on social determinants of health again. So policymakers and researchers started to look at housing, food insecurity, social services integration, and how a lot of this affected delivery system, the healthcare delivery system, and could lead to reforms. So during this time, I've been working at Mathematica mostly on state and federal evaluation projects. One of the projects I worked on was for the Colorado Health Foundation. So we looked at the impact of team-based care across 20 clinics in Colorado. So this is a good example of state work that we do in addition to federal work. I also worked on a pretty large evaluation of the CMS prior authorization model for repetitive scheduled non-emergent ambulance transport. This was a really cool project and a great example of how research translates into the real world. As a result of this evaluation, CMS expanded this ResNet model nationally after finding that it saved Medicare money while preserving quality of care and access to care. We've talked about COVID quite a bit so far in some of the other talks, so we all know what happens in 2020. The emergence of COVID came in as a shock to the healthcare system and a stress test for policy and health services research. COVID really reshaped health policy priorities, accelerating telehealth adoption, emergency regulatory flexibility, real-time data use, and research focus on system resilience, as well as access and inequities. We started to see a huge shift in health services research, emphasizing rapid cycle analysis. COVID was changing so quickly at this time, we had to be able to conduct research and get it out as quickly as possible to be able to implement change. In my work as a researcher, there continued to be a lot of work in this federal space, but we also started to see a lot of quick turnaround opportunities related to COVID. I worked on a really cool project with the CDC. So I co-led this project where we conducted mixed methods research, looking at individual experiences with contact investigation and contact tracing. I also had a lot of personal life changes happen during this time. Both of my daughters were born during COVID. So this was my real introduction to chaos and sleepless nights. I also experienced firsthand, though, how the pandemic really stress the healthcare system from my own experience. I went through 2 entire pregnancies and follow-ups in Washington, D.C. during the pandemic, which definitely shed a lot of light into what was happening and how quickly the system was changing. So now I want to talk a little bit about health policy and HSR right now in the current moment. I want to use the Make America Healthy Again initiative, or MAHA, I don't know how it's pronounced, as a foundation for this section. So let's say MAHA. It was formally launched in 2025. And there are a few points I want to focus on that really drive federal evaluation work. So a lot of the work that I do. So first, this initiative identifies and addresses, or aims to identify and address, the root causes of chronic illness through coordinated federal action and prevention-oriented strategies. Next, the initiative seeks to reform nutrition and food environments to improve health outcomes. MAHA also seeks to strengthen scientific research transparency by placing emphasis on expanded research into chronic disease prevention, environmental exposures, and other health drivers. And as a part of reforms, HHS, or the Department of Health and Human Services, is restructuring its agencies and prioritizing primary care, prevention, and addressing systemic inefficiencies that exist at HHS. Lastly, there are a lot of tools through this initiative, like a tracker that highlights progress, encourages state actions to align with federal priorities, and promotes campaigns on nutrition, physical activity, and health information access. So a big part of federal evaluation work comes out of the CMS Innovation Center, which was created under the Affordable Care Act to test, evaluate, and scale innovative healthcare payment and service delivery models. Right now, I feel like there are about 20 to 30 active models, but there are some more recent models that came out of the MAHA initiative that I wanted to highlight. And I imagine we'll be seeing more models that look like this in the coming years. So the first model is WISER. This is a 6-year innovation center model beginning this year, and it's going to use enhanced technologies, including AI and machine learning, to streamline prior authorization and reduce low-value, unnecessary, or potentially wasteful services in original Medicare. Elevate is another model. This is a voluntary cooperative agreement launching this year as well to evaluate evidence-based whole person functional and lifestyle medicine interventions that are not currently covered by Medicare. Balance is a model that will also launch soon, and this is going to be a voluntary model that's going to help to negotiate pricing and coverage for certain GLP-1 medications with manufacturers on behalf of state Medicaid agencies and Medicare Part D plans. And lastly, there is LEAD. This model will launch in 2027. Also a new voluntary accountable care organization model that's going to build on prior ACO tests and offer enhanced payment flexibility and benchmarking to support coordinated accountable care for diverse providers. So I guess I'll close here with a few points and then open the floor for questions for me or any discussion that you all would like to have. But I want to highlight 5 points that we can expect around health policy and HSR in the future. So first, I think we can expect policy change to be incremental, but maybe not transformational. Most health policy changes will build on existing systems and not really seek to replace them. Research may focus on identifying opportunities for improvement within these current frameworks and demonstrating practical, scalable solutions. The second one, which we see a lot in this evaluation space, we're going to have to learn how to make research faster, flexible, and more policy relevant. Policymakers are seeking evidence in real time, not years after decisions are made. So a lot of our previous evaluations were, 5, 6 years, and now a lot of clients are requesting feedback in the matter of months, and determining whether to scale a model or to make changes. So we're going to have to be quicker and more innovative in how we draw some of these conclusions. Health services research as a whole, we're just going to have to learn more rapid cycle evaluation and adaptive designs that directly inform policy decisions in a more quick fashion. Thirdly, real-world data, AI, and advanced analytics will begin to play a larger role. So administrative claims, electronic health records, registries, and other data sources will become central to generating timely insights using AI and advanced analytics. Equity will remain a central organizing principle. Equity considerations are going to continue to guide study design, data collection, and evaluation metrics. We might not always use the term equity, might show up in a different way, but all in all, we still want to continue to ensure that interventions improve outcomes for all people. And lastly, trust, transparency, and usability of evidence will determine influence. The impact of research depends on whether policymakers, stakeholders trust the methods and can apply findings. So it's going to be important to have clear communication, reproducible methods, and actionable recommendations to shape policy and practice in the future. All right, that's the end of my presentation. I want to open up the floor for questions. And like the other presenters, don't hesitate to reach out to me directly if you have questions, comments, or want to talk through anything policy or career-wise. You can reach out to me by email, or you can find me on LinkedIn. Thanks so much. I'll pass it back to you, Ray, or open up the floor for questions.
Yeah, excellent. Thank you, Geraldine. I had one question for myself and other folks. I'll encourage you to use the Q&A to submit. On the bullet points you had at the very end of a few things that will change in the future, speed and timeliness of research to be acted on for policymakers was one that you emphasized. Can you talk a little bit about what the pace of work is like sitting inside of Mathematica versus somebody who might go into academia, and how that might influence either maybe it's a personality fit that's better, or for different types of research that are better positioned to be executed on in an institution like you are versus being a part of a university?
Yeah, it's a good question. And I think academia is going to have to learn to be faster too, right? I don't think it's specific to industry, but I think it's going to be harder for folks in academia to make the pivot. Yeah. So I think it's going to change across the board. That's my easy answer. But I will say, in the research world, we get a lot of more pushback from clients and from stakeholders, and have more interim check-ins to make sure that things are moving along and in time. So I think it's a little more process driven and timeline driven than sometimes it can be in academia, which makes it different. But I think to be successful in getting, some of these grants and getting some of these research dollars, going to have to be similar in academia. It's going to be shorter turnarounds for feedback, shorter turnarounds for publication with fewer dollars. So I think it's just going to be something we have to adapt to across the board.
Yeah, well said. There's a question here about what alignment do you see in your work between health services research and implementation science, if any? It sounds like Jada is also curious about whether implementation science as well as health services research help with this speed and timeliness of research.
I think there's definitely some overlap. And, I want to say in the consulting world, it's, sometimes it can lean more heavily on the implementation science piece of things. There are so many moving pieces at Mathematica and at companies like Mathematica. I think you have to keep sort of implementation science as a central piece while working around what methodology is important to do and what you should be doing around that. So I think they interact quite a bit as well.
Yeah, awesome. Another is from a colleague asking about what more do you think we could do as Ron Brown to help facilitate connections between students and for shadowing opportunities and advice or PhDs, maybe reflecting on your own experience through the different chapters that you went through. We do it for finance, we do it for tech, we do it for other industries, but we've been talking a while about what more we could do in this space for that.
That's a hard question. I think that's a hard question. I do think, that some things like this help, right? Like you had doctors on the panel, you have PhDs on the panel, you have people from different walks of life who do different things in healthcare, all sharing their experience. So I think always including a research voice is helpful. But I also think on the scholar side, like don't hesitate to be vocal about your interests and to reach out to scholars doing things you might be interested in, things that might seem out of the box, or talking to folks who are not scholars, about career paths that you're interested in. So we're out here. There are a lot of PhD scholars, I think, that are open to conversation and chatting. So don't hesitate to reach out and and see how our work integrates with what you might be interested in.
Oh, thank you, Geraldine. That's fantastic. I wish we had more time, as we always do.
Well, I'm around. If anybody wants to talk, I'm always happy to chat. Thank you.
Yeah, appreciate your openness to do so, and I think there will be many people who take you up on the offer. So just thank you for spending spending some of your afternoon with us, and appreciate your session. All right, y'all. We have 2 more talks left. Next, I'm excited to welcome Lowell to this stage, and I'll make sure that Lowell has the spotlight that he deserves for this conversation. Lowell, great to see you. I'll introduce you a bit here, and then I'll leave it to you to add any more color to this that you'd like to. But Lowell is a 2005 Ron Brown Scholar, originally from Indiana, graduated from Penn, and did the dual degree Huntsman program in both in business and international relations there. He spent some time in finance and then started at Harvard Business School and took a leave of absence to go start a company, a very innovative healthcare delivery service company focused on dental care. And we had a fun time reminiscing on that story of what that company was on our podcast. Then he joined Included Health and now sit as the Director of Partnership Growth at UCSF Health. And I really wanted Lowell to come to talk today about his role and his journey in healthcare that's a bit different than all the other speakers that we've had. You know, our first half of speakers were very clinician heavy, talking about what the future of healthcare looks like from the perspective of people who practice medicine every day. And Geraldine's talk about health services research more broadly and policy has introduced us to this back half of talking about all of the other things that we will need to fix in addition to how we actually practice medicine. And Lowell's role right now, as well as all that you've seen over the last few years, I think will be great for other people who may not want to be doctors, who may not even want to be researchers, but just have an interest in this space, still figuring out where they fit and what things they can explore there. So I'm excited for Lowell to come on and to share his journey. I'll be going back and forth with him with some questions. Lowell, anything that I missed that you want to make sure? Dad? Dad?
Right, that's right. I'll just say I appreciate the invite. It's an honor. I love chatting with you. I do it a lot. So I'm excited to have this conversation. I don't know who else is on, who's watching, but I felt like when I was going to college, leaving college, and early in my career, just had very limited knowledge of what the range of jobs are out there. And so I went into finance, like you said, and after that, I just went to start my own thing. But I think I would have really benefited from knowing more about what other range of jobs are. So hopefully I can talk a little bit about my job, and that'll be helpful to someone who's listening. And super open to questions. So anyone who's got them, put them in the chat, and I'm happy to answer questions as they come up.
Yeah, awesome. Okay. So let's start with the nitty-gritty of your title, because it's one that most people have not probably seen or super familiar with or intuitively know what it means. And specifically, what is the problem or challenge or opportunity that your role it was created to solve? Like what, and the reason why I'm asking for the larger context is you're sitting in a part of the health system that most people, at least as patients, don't have much visibility into, that we hopefully benefit from. Yeah. So yeah, I'm just hoping we can start with better understanding what you do and why it matters for UCSF Health and other big health institutions across the country.
Yeah. So I'm Director of Partnership Growth at UCSF Health, which is a hospital system that is anchored to an academic medical center. And I think it's relevant that that is one type of health system. There are other health systems that are privately owned and run. There are other health systems that are owned by districts and municipalities. There are other health systems that are small community-based health systems. And each of those different health systems are good at different things and operate in different ways. And academic medical centers in particular are sort of the core, asset that they have is their faculty that is and particularly at UCSF at the sort of cutting edge of their field, both in terms of researching and understanding new therapeutics, but also using new technologies to do new surgeries or do more complicated work. And so that's what UCSF is really good at. But UCSF health is not as good at, for example, or hasn't historically been as good at things like that is not as specialized. So things that are like general primary care or not as complex specialty care. And so that is really the opportunity of the partnership, is to find partners who can help fill in the gaps of the types of care that UCSF Health is not the best at. And so there's, this role is exploring the ways and figuring out the ways that we can expand our scope of services through partners.
Yeah, excellent. And you can tell me if I have this right, that UCSF Health has its sweet spot of things that it does well. And for all the other things that it needs to still and wants to provide for its patients, it can tap other nearby systems or other colleagues to do so. Can you give us an example of a type of thing that a system like UCSF Health would go out to seek a partner to do better or more? And then maybe the opposite too. What is something that someone would come to UCSF Health and want to partner, maybe to fill a gap that they need filled on their end as well?
Yeah. I think one good example that I think about a lot is neurosurgery. Neurosurgery is a brain surgery and surgery of the spine, are surgeries that are highly specialized and not many people in the world can do them, but they're also very rare. And so you need a large population to have a decent incidence of brain surgeries. And so for UCSF's brain surgery division, they like to partner with health systems that are not within San Francisco. So they have access to more patients and they have a wider catchment area so that they can have more higher incidence of brain surgeries. And so the neurosurgery department likes to partner with other health systems to get that volume. The health systems that we partner with like that we are partnered because they can offer UCSF quality neurosurgery in their communities in a way that they would not otherwise be if they would not be able, they wouldn't be able to hire a neurosurgeon for themselves because again, there's just not enough volume or demand for that particular service. So a lot of the interchange is, UCSF exchanging its quality physicians so that it can reach new markets, and this community hospitals benefiting from having that level of quality in their local communities.
Yeah, I can see that. And how and maybe it's just a matter of logistics. How wide of a net would a UCSF cast of places it would be willing to go? Or is it geographically limited? Maybe it's limited just by there are places where it's easy to get to by plane or whatever the case may be, even if it's out of the region, or is it kind of more localized in the Bay Area? That's the main focus.
I believe the UCSF charter is limited to California. We're part of the University of California system. I don't think that we, at least not since I've been here, been exploring partnerships outside of California. But there are other very specialized health systems like MD Anderson or Mayo or Cleveland Clinic that are not limited by that geography. So you may see them partner outside of the state or across the country. I think, I've seen recently Kaiser has been doing a lot of partnerships across the country. So, I think the benefits of it, if you're trying to grow, the more geographies that you're in, the better. But then, whether or not it makes sense for the organization, I think depends on what that organization's charter is, what their mission is, what their goals are.
Yeah. Yeah, that makes sense. Can you walk me through what the economics of a partnership look like? Like, I can see why a neurosurgeon at UCSF doesn't want to wait once every 2 weeks for some or every month and just for this city and wants to go elsewhere. Does trace how money flows to where it's a win-win for all of the parties involved? Maybe we can assume that we can start at payer and not go earlier than that, but starting at payer through all of the different entities that would be involved in like a rare neurosurgery type incident.
Yes. So it's US healthcare, so it's complicated and it differs depending on the partnership, depending on the partners. But I would say a couple of the big pieces that happen where the care is provided in a place by a person. And in the US healthcare system, when that care is provided in a hospital, then the person can charge for the care that they provided and the place can charge for the care. So when you go to a hospital, you leave with the hospital bill, you've got charges from the doctors that you saw and you've got charges from the hospital. that gave you a bed and gave you an IV and all that. So those funds go somewhere. And then there's an agreement between the two health systems of whose costs, what costs are you going to cover? What costs am I going to cover? And then that money that came into the system from the payers gets divvied up based on that agreement. So there are some agreements where the health system says, where, for example, the academic medical center can say, hey, all you have to do is cover the cost of my doctor. So you take all the money that you collected from both your professional fees and technical fees, and you pay me enough. You pay me what I pay the doctor, and you can keep the rest. There are other agreements where you say, we got money from the insurance company. We want 50% of whatever you got, no matter what it was. And just, and the full range in between. And so I think the big components are who collects the money, like where does the money come into the system from the payer first? And then what's the agreement between the two partners about how that money is divvied up?
Yeah. Okay. That makes sense. I guess shifting over to logistics, is it common for, maybe it depends by who is doing the work, is it common for a UCSF type entity to tell that partner health system to bring their patients to a UCSF health facility, and therefore they would do the capture and the split? Or do surgeons go out to various places and use their facilities, likely their team and all those other things? I'm just thinking about my own experience. Tore my meniscus, had a meniscectomy, but I went to like a kind of an independent network of ortho doctors, but had the actual procedure done at a relatively major hospital. Realized I may have been a beneficiary of one of those relationships you're talking about.
Yes, yeah. So another way to break down the care that's provided is like you have clinic or just sort of evaluation visits, and then you have procedures. And so when I'm sending a UCSF neurosurgeon to another smaller town, they're just holding clinic. They're just meeting patients. They're just evaluating people. They're just diagnosing stuff. They'll never do a brain surgery in a small town. They'll bring all those folks back to the city. And so that's sort of, you're seeing there why UCSF wants to have a neurosurgeon, see patients twice a month in a smaller town. It's because they can capture that demand and send them back to, the mothership to get their brain surgery, where UCSF will capture fees for being the facility that provided the facility where that work occurred.
Right. That makes sense. And then divvy back to your partners per your agreement later on. That makes sense. Okay.
Yes.
Excellent. Fascinating breakdown for me of clearly things I didn't even realize I was experiencing. But,
once you follow it's such a good question, because once you follow the money, it helps to understand why do I have to go into the city? Why do I, why is it difficult? Why is this doctor only here in this office twice a month? Why, and it's all about, how the payments are working and what the partnership agreements look like.
Yeah. It's fascinating. I want to shift the conversation to a version of partnership that's a bit higher than that. Is not just health systems collaborating on unique use cases and partnerships like you're talking about, but when health systems acquire each other or merge together or buy each other's assets or shift things around. What is the health system on either side thinking about that? So maybe before we get into any details, can you just lay out some basic examples of why one health system would want to merge with another, or why it would buy another? Is that usually a good thing? Is that a bad thing? Is that mean someone is losing in this deal and that's just kind of part of business? Yeah, I'm just curious about your thoughts on M&A and health systems more broadly.
Yeah, I mean, some of the motivations behind buying in healthcare are similar to other industries. You want to expand your geographic presence, you want to expand the scope of services that you're able to provide, or you want to sort of be opportunistic and buy something for cheap that, you think that you can turn into value later. I think those are the motivations for a buyer in a lot of industries. So, I think health systems are one buyer in healthcare M&A, but you also see a lot of private equity buying in healthcare. And I think those buyers are more interested in buying something that is cheap and investing in it to increase the value of it. And so, yeah, I think those are sort of the reasons why a health system would be interested in buying or merging. Was that does that answer your question, or was there a second part?
Yeah. Yeah, that's perfect. And maybe the follow-up is what are different examples of when you've seen that might not go as well as we'd hoped? And
Yeah.
maybe not just that, maybe it goes super well for private equity firm that bought a health system, but either leaves a certain community in underserved, or there are a lot of folks on here similar to yourself who have business backgrounds, a lot of MD, MBAs who have been speakers, a lot of folks who will probably sit in the positions where they may even make some of these decisions or might get jobs where they're thinking about these things. And so, yeah, I'm just curious about what your thoughts of what is important to keep in mind or what hopefully do people keep in mind as they try to execute these different transitions?
I think what I want to express is that it's the same as outside of healthcare. What I can speak about from UCSF is UCSF very famously had a failed merger with Stanford. I want to say like in the 90s. And these are two academic medical institutions, both on opposite ends of the Bay Area. Them working together, they'd be able to share resources. They'd have more geographic reach. We compete a lot with them. So that would have, if we weren't competing, like I think there would have been better collaboration for all the partners. And on paper, it just made sense. But they could never get it to work just culturally. Like I think it fell apart after 2 or 3 years because they just couldn't do the integration. And who knows if that was a leadership problem, if that was, if a different leadership team had been on either side, would it have been more successful? Or is it a culture problem? Like this was never going to be successful. Who knows? It wasn't around, but I think that happens in M&A. And then I'll say, we recently, this is information in the public domain, acquired 2 hospitals a year and a half ago. And, I'm hopeful and I think that I know that that's going more successfully than, merging with Stanford. And I think the difference there is sort of what, is the leadership ready for it? Does the team have the ability to integrate the new assets? And, how strategically important is the acquired asset? So, for the failed decades ago, maybe it was like, you know what, if at the end of the day, if this doesn't work out, that's totally fine. But it feels like the acquisition that we've recently made, that acquisition is very strategically important. And so it's like, we got to make this work. We got to figure this out. So those are some of the things I think: leadership, strategic fit, timing, things that you can't predict, all sort of come into play when figuring out if these deals are going to be successful.
Yeah, that makes sense. You talked about the Stanford UCSF failed merger. I can see a situation where institutions like that would compete, certainly on talent of where people want to work. Yeah, I guess I'm curious about what you meant by the competition. Are there other forms of competition that you see health systems engage in that we may witness or not even really realize is happening?
It's for patients. For patients. So UCSF is in San Francisco. Stanford is in Santa Clara. These 2 locations, in between these 2 locations are a bunch of people who need healthcare service. North of these locations is a bunch of people. South of these locations is a bunch of people. And so it's like, when someone needs something, where do they go? And you compete by, having a brand. You compete by having clinics in places that aren't your main campus. You compete by being convenient. You compete by having word of mouth. And all of it is, your market share is determined by the decisions that patients make about where to get their care done. You can compete based on, the insurance networks that you're in. So, yeah, it's all about patients making decisions to use services at your facilities versus the others that are available.
Yeah, and I live in Chicago, and we've got a lot of health systems that all just driving on the L or the train, a bus of lots of different clinics, brands, advertisements. So I can see that or come out but I guess it's a little funny to think about that this is all just to take care of people and for health. But so
it is, and that's the beauty of healthcare. I think since I've been in healthcare, it's like at the end of the day, when you leave, whatever you did at work, it was to help somebody.
Yeah.
feel better, repair them, in dental, I feel like dental had a big sort of emotional component in the ability to sort of change the way they view themselves or their self-confidence through my work was um, really nice to go home at the end of the day with knowing that's why you were working or what the end product of your work was.
Yeah. Yeah. Yeah, absolutely. We're coming up already to the last few minutes. I highly encourage people to drop in the chat if you have any questions as I ask my last one to Lowell. I think just going back to the beginning, you have a really cool lens on the healthcare system that most people don't see. How did you hear about this? Did it find you? Is this something that uh, is common amongst the bigger health systems that people could keep an eye out for? Is there anything of somebody who might have been listening to this and would have loved to listen to us talk about this for much longer can go do or learn or explore that would best prepare them to be in the types of rooms that you're in now? Yeah, I'm just curious, or maybe we can blow it up to more broadly, just career advice for people who might be interested in following you in your footsteps.
Yeah. I found the role through a, personal relationship, but I would say this role is similar to, I guess I came to this role from entrepreneurship, but just around the business of healthcare. So if we're talking generally about the business of healthcare, um, uh, I think the best way to, I think a really good way of understanding it is just being really close to care delivery. And that actually is what really motivates me is being close to helping to organize the work around care delivery. So when I was building Studio Dental, a lot of my work was how do you build a system that allows you to deliver care? And I think, since not a clinician, didn't go to medical school, and if you're like me and interested in being in and around healthcare, I just think it's important to have a really deep understanding of what it's like to deliver care emotionally, like operationally, financially, and doing roles that help you to understand that depending on where you are in your career. I mean, like being a scribe at a medical office or just being in and around places where care is being delivered, you understand what's happening on the other side of the desk, right? I think as a patient, to your point, you show up and you get your service and you leave. But the business of doing that day in and day out, 6 days a week, 10 hours a day, it is something that a lot of people don't have a lot of insight into. And I think I've really benefited from being sort of on the ground of care delivery. And then I think that's helped me to understand help me to relate to like providers and people who are clinicians, but also help me to really understand what good care looks like and, what people's problems are, what the problems are to solve.
Yeah. Yeah, it was well said. I don't know if I see any questions have come in yet, but maybe we could spend the last few minutes. Can you tell this audience a bit about Studio Dental and what you did? And I know we spent maybe an hour talking about it a couple of years ago. People can go listen to that. I don't want to force you to compress it to 60 seconds, but yeah, it was awesome. And I think without that, it sounds like you're saying it's hard for you to see how you would have had the perspective and the lens that makes you successful in your role now without building something from scratch that was working with people very directly. So yeah.
That's just me. That's not to say someone else on here can't be on my path without having had the entrepreneurship experience. I think it's not for everybody. But Studio Dental, when I started Studio Dental, I had a really close friend who's a dentist, and um, none of my friends had a dentist. And it was, when you talk to people about dentistry, it was like they couldn't find a dentist in the city. And I live here in San Francisco. And so people here had dental insurance from the best companies. This was back in the early where tech companies were really competing with each other on benefits and, making it really attractive for someone to be employed there. And so while people had really amazing coverage, they weren't using it because they couldn't find a dentist. And, idea was, what if we could take the dentist to them? And could we bring a dentist to someone at work and make it really easy for them to use the service? And so we designed a dental office on wheels, and we partnered with different tech companies here in the city. We partnered with like Airbnb and Twitter and square, and we would bring the dental office there. It was like this really high-end, chic trailer that had 2 dental chairs in it, and we'd just show up and set up an online scheduler. Folks would schedule online, and we'd be there for 2 weeks, and we'd do a bunch of cleanings and exams in the Monday and Tuesday, and the rest of the week we do more cleanings and exams, but also save room to do fillings, Invisalign, crowns, and we do all that work in the mobile office. So we did that for 2 or 3 years. Then we built a brick and mortar office, and we had sort of a hub and spoke model where we used our mobile offices to do customer acquisition and then funnel those folks back to the brick and mortar, and grew that. Then COVID happened. We got much smaller. People stopped going to work, and so we just had the brick and mortar office. And then in 2022, I sold the business and took some time off before going back to the workforce.
Very cool. One of the coolest businesses that I've heard in a long time. Well, all we're a little bit over time, but this was fantastic. Actually, we got one question, and this is a great one. So yeah, this is a bit back to the competition element to it. When hospitals are competing for the same patients in the same area, how do you think about the ethical responsibility when one hospital system growing and doing better might negatively impact the neighboring systems that perhaps looks great on a P&L, but stepping back as a citizen, you probably would want all of your health systems to do well and not necessarily to see one very much struggling and another that's great, since ultimately that'll trickle down to whoever has to still use whatever system might be losing. How do you make sense of that and the competitive aspect to it, but also the kind of positive sum framework that I'm sure you bring to your work?
Yeah, that's a good question. I mean, I think I may have an unsatisfactory answer to that question. I mean, I think like when health systems are in the same area, what is really effective is when they sort of specialize and do what they do best. So, if ideally UCSF is taking the brain surgeries, but maybe a smaller health system is doing things that are more important to have people locally and in their community. So if that's behavioral health or primary care and specialty care, right? This works best when the organizations figure out what they do well and do more of that and not compete. So the best competition is like UCSF competing with Stanford. It's like we offer the same types of services, same level of quality. How can we make it more convenient for the patient to consume our services? And I think those are the types of competition that result in better care for people and just better options for patients. But you also see competition where, a big health system is growing and growing and growing and squeezing out smaller community hospitals. And I think that might be what this question is speaking to. And I think there are, some financial, I think in both those situations, again, each party, its best is doing what they do best. So if a smaller system is better at understanding what the local market is and better understanding what the local needs are and better at delivering like meaningful personal care, they should be doing that. With the larger health system, maybe taking on some things that are more complex, that are harder and more costly to do in a smaller health system.
Yeah, I like that framework. That's great. Well, this has been great. Feels always short and sweet, but super impactful, and appreciate you giving us a lens into your world and your angle on the healthcare system. It means a lot.
I appreciate you organizing this.
Yeah, absolutely. Thank you for being a part of it.
Have a good afternoon.
Yeah, you too. Take care. All right, y'all. We are closing in on our final talk. I'm excited to welcome Travis to join us. Travis is a 1997 Ron Brown Scholar, fellow Duke alum, fellow Blue Devil. He then went on to U of I for his MD and PhD. He spent time as a researcher at the NIH, has taught at several universities, I think at least all of the ones around here, Northwestern and DePaul, I think Hopkins as well, probably the University of Maryland. I know you spent some time there as well. He was also the chief medical officer for DC's Department of Health. And then he was also the chief of public health services and medical officer for Montgomery County in Maryland. Roles of serious leadership, especially during the COVID-19 pandemic, that he spent some time talking about on the podcast as well. He was also the chief health officer of an awesome startup, Hazel Health, as well, and is now the president and CEO of Howard Brown Health, which is a nonprofit LGBTQ healthcare and social services provider based here in the Chicagoland area. And so, Travis, thank you so much for being here, and appreciate you taking the time to join us. What more color would you like to add to your intro or to your bio that maybe I didn't mention, aside for your continued passion for our Duke Blue Devils and everything?
Well, we should take first of all, thank you for the opportunity to be here. Good afternoon, everybody. Good to be here with you all. There's an important basketball game tomorrow, so we just want to make sure that those who are watching basketball understand that there's one team that will win tomorrow and hopefully win in April. So no, I thank you for the very kind introduction and biography.
Yeah, awesome. We got a chance to dive into some of your career experiences on the podcast a little bit earlier, a few months ago. So anybody who is very interested in Travis's background, I encourage you to go listen to that. We're going to touch on that, I'm sure, in a variety of ways through our conversation. But I wanted to invite Travis to come speak about federal qualified health centers in particular, FQHCs, which Howard Brown Health is. And there are a few different reasons why I thought this audience would find diving into this particular type of institution in the healthcare system interesting. One is that it is kind of the backstop of serving anybody and everybody who needs it, and that many Ron Brown scholars and captains, generally speaking, go to great schools and therefore have access to go to the most prestigious health systems in the world that they can go work at. But a lot of them also have a deep passion for equity and access that may lend itself, not necessarily better or worse, but just a different angle, being an institution that's specifically set up to serve those who are underserved and less fortunate. And so that's one part, is that intellectually, I think most, not all of Ron Brown scholars and captains will find learning about this structure interesting. And then the other side of it is that most of the time when I talk to alumni who are interested in starting their own practices or starting their own healthcare systems or starting their own organizations within this space, equity and access is at the center of it. And normally understanding how this institution that's already exists functions can be helpful as they think about how else do they want to create new things that don't yet exist. Sometimes at the venture lab that takes the form of tech startups, but other times it can take the form of perhaps starting a center like this in a town or a city that needs it. So I think that I think Travis's perspective will be great, and hope that the audience gets a lot out of it. Maybe, Travis, we can go to 101 first. For those who are less aware, can you talk a little bit about what a federally qualified health center is? Maybe a little history, if you have it, of when did they come about, why do they matter, and yeah, just kind of lay the land for what we're talking about, even as it relates to these types of entities.
Sure. So thank you again for the opportunity to be here. I unfortunately didn't get to hear everyone's presentation, but really excited about the level of excellence, the significant experiences, the entrepreneurship, the service of all of the different presenters. And as we know with the Ron Brown family, this is just a sample of the depth of all of that throughout the program. So federally qualified health centers have been around for a while. They've been around for a number of decades. And ultimately, they were created to, as Ray mentioned, to provide a stopgap, a safety net, if you will, for folks who didn't have other options. Now, we've grown up in or recent generations have grown up in a time where the country has supported, for the most part, insurance for everyone. That hasn't been the case. The 80s, 90s, insurance was not something that was guaranteed. And so we had a significant percentage of folks who were uninsured. And we're not talking about underinsured, but truly uninsured who had no opportunity to get insurance. Now, over the years, the employer-based system has grown as it has become more financially profitable and appropriate for them to offer those services and competitive to their employees. But for years, there weren't. And so in many instances, as you can imagine, those who did not have a lot of money or were lower income folks did not have options. Out of that need grew this movement federally qualified health centers. Federally qualified health centers have certain regulations and parameters that they have to meet in order to be an FQHC. FQHCs are governed by HRSA, which is part of Department of Health and Human Services, which causes some issues now, given the federal government's socio-political stances in a number of places. But federally qualified health centers are regulated by HRSA, the Health Resources Services Administration. And so there's certain things that are in place. So for example, our board has to be majority patient-centered. So over 50% of the members have to be patients and clients of the organization. There has to be a commitment and opportunity to accept all types of insurance. And for individuals who struggle or have an inability to pay, there must be some type of sliding fee scale available for them to be able to access and utilize services. Now, over the years, the number of components of required things that you have to offer has changed. And again, that's been influenced by, again, who's in control of the federal government, who oversees HRSA. But at the core, we have to provide primary care services. In many instances, for us, we actually have a dental clinic program. I heard you all talking about dental services, because access to good dental services is a significant problem, not only for those without insurance, but even those with insurance as well. And we also have a behavioral health component to our program. So we provide holistic, whole person primary care, and offer the opportunity to be a medical home for individuals who need those services. For us, historically, Howard Brown was started 50 plus years ago as a space actually initially offering hepatitis services when hepatitis services were not offered elsewhere, and members of the LGBTQ community could not get those services at other places due to discriminatory practices. Over the years, we've grown significantly. We became an FQHC in 2016 and have 7 different clinics throughout the city. And while that historic interest was in the LGBTQ community, and that continues, we offer services for, as I say, anyone, no matter who you love, what zip code you live in, what languages you speak at home, or what type of insurance you have.
Yeah, that's great. I appreciate you framing a bit of the history, which was new for me. I didn't know about Howard Brown. I guess it's 2016, the transition. And I know you weren't there at the time. What led to that transition? And maybe actually taking a step back, what was the structure before it became a federally qualified health center? And that if someone is interested in this, creating organizations to do this type of work, is there kind of a step that needs to happen first before you kind of, I imagine, a bunch of administrative legal?
There are quite a few.
Yeah.
Well, Howard Brown, it actually started as, interestingly enough, it was, I think, a group of 4 folks. There were a couple of medical students and residents who started a free clinic. And that was the model. It was a free clinic model that operated out of a storefront, like 1 or 2 days a week, that folks could come in and get services. And it grew over time and became kind of a de facto nonprofit community health center. And as the need grew and the desire to expand throughout the city grew, there was a recognition that in order to truly support that in a meaningful way, it made sense to go about the pathway of becoming an FQHC. And again, there's lots of, in order to get that status, there's lots of regulations that you have to pass and rules that you have to follow. And again, that becomes interesting because, again, in the socio-political environment, some of the things that we have to face and deal with is HRSA saying, in order to be eligible for the grant that you qualify for to be an FQHC is called a 330 grant. For example, they've come out and said, your 330 grant, none of that money can be spent on equity, health equity stuff, anything LGBTQ related, gender affirming care, any of that, in order to continue to be eligible for that standing and fund. And that's the first time that's happened in the history of the program.
Yeah. Well, does that mean for you that you literally can't legally do any of those services, or you would have to go find other funding? You could still do them, but something else besides 330 would have to fund that kind of work.
So a lot of it is really savvy accounting and understanding where funds are going. So we, like any other center, make sure that when there is a rule in place that we are compliant. And so if there are certain stipulations on how funds can be spent in certain areas, we make sure that they are spent appropriately to be compliant with whatever regulation is in place. It also forces us to be very thoughtful, though, about how we partner with other organizations to be able to provide services. Additionally, there are a couple layers. So while FQHCs are regulated on a federal level by HRSA, most folks, or a significant percentage of folks utilizing FQHC services, are on Medicaid. Medicaid, while it does have federal oversight, is a state-run program. And so a lot of your ability to function as an FQHC, while you do have those federal regulations, is influenced by your particular state's Medicaid rules. We happen to operate in a state that is Medicaid friendly, and that is also, from a socio-political perspective, friendly to the types of services that we have historically provided and we continue to provide. So that does give us a little bit more wiggle room than, say, an FQHC in Indiana or Kentucky or Iowa or Tennessee, some of our neighbors.
Yeah, that makes sense. And just double clicking into that is, where does the 330 grant sit in your revenue and what it can and can't cover? And then you're also thinking about your own payer mix of your own population, and certainly serving uninsured folks, I'm sure, if they do come across. But you also have other folks, including Medicaid and other types of systems. Maybe you can kind of paint the picture of the web of where does all of the money come from and what sources, and kind of how do you think about that, or I'm basically asking how you do your job. How do you plan around a lot of different systems
on the
all
day.
come together? Maybe is a different kind of complex than other systems, but I think there's a few other variables that other institutions wouldn't have to consider or think about.
Well, it's an interesting question because I think it helps frame and I think you were getting to this in your purpose of including this session here. So hopefully I'm in line with that. I think the thought is that historically any entity like an FQHC or a nonprofit health center is on a shoestring budget.
Yeah.
That it is operating out of donations and philanthropy and goodwill.
Yeah.
FQHCs are, yes, a safety net, but they also are corporations. And so our budget is, we are a $250 million entity. We're growing. My goal is to get us to $1 billion by 2030. Now, of that mix, most of our funds come from insurance payments, which is a mix of public insurance, Medicaid, and also a mix of private insurance. And so interestingly, that influences how we market and how we try to attract and retain patients. The 330 grant that you referenced is, I told you we're an operating entity of about $250 million. The 330 grant is actually only about $3 million. It's not a huge grant, but in itself, in terms of the funds, but having FQHC status opens up your eligibility for a host of other programs, such as the 340B program for drug pricing and revenue. And so, for example, eligibility to participate in that program opens up the opportunity to be eligible for drug rebate funds that are then repurposed to pay for a host of other types of services that FQHCs don't have the revenue of. I heard you all talking about a UCSF, or Stanford, or Northwestern, or University of Chicago. So while the grant itself is not a significant amount of money, and for example, for our operating budget, for some FQHCs, it is a larger portion, the programs that we are eligible for allow us to keep our doors open in other areas and be able to support other programs. And so much like other institutions as well, we do have a development team that looks at foundation opportunities and partnerships. Because again, a lot of the work that we do isn't unique to us, but there are opportunities to secure funding where, for example, we may not be able to use Grant X to talk about equity or do equity work officially, but other funding opportunities are there to be able to address those particular needs and activities.
Yeah. Okay. Very cool. Tell me, as much as you can share, what does taking Howard Brown now to $250 million to $1 billion in 4 years now look like? What types of things are on the horizon that you all plan to do? And does having this status it sounds like maybe at the scale helps you unlock some other things, but is this status a big part of that scaling, or is it perhaps as Howard Brown Health continues to grow, might matter less and less that it has the status, or maybe that's not the goal. Maybe is that the goal? Is to hope that it becomes like the peer institutions here in Chicago of, you know, Rush and Northwestern and U Chicago and all that.
Well, we'd be limited in that because we don't provide hospital services. So and at least as far as I know in my tenure here, we won't be offering hospital services. That may change. But I think as an extension of the last question, I think part of, and to bridge to this question, I think when folks think of FQHCs, they think, okay, I'm going to go somewhere that's on a shoestring budget, not get paid competitively or comparatively to the other health systems, as you alluded to, you know, when you're looking at an offer from a Northwestern or you know, Hopkins or things like that. From a financial perspective, it may look different, and kind of a reputational perspective. What we're really aiming to do, which will drive that growth, is to reframe how people think about FQHCs. I want people to think, yes, it is an FQHC by status, but that doesn't mean it's any lower in terms of the quality of your healthcare experience, the quality and access of services you have access to. It should be on par. Your patient care experience should be on par with any of those other institutions, the Northwesterns or VOC, or any of the other big institutions across the country. So we're working really hard to change that perception. Yes, we are a safety net for those who don't have anywhere else to go. But for the individual who does have a really nice income and private insurance, we also are an attractive option to you to be your primary care provider as well. They built a new center a couple of years ago that has a dental clinic that whenever I bring folks through, and they're like, this rivals or beats most private practices. Exactly. Just because you're utilizing or going to an FQHC doesn't mean you shouldn't have a high quality experience comparable to anyone else. And so that's the big piece where we're driving. And then that's the piece that attracts the really accomplished person who's looking at all these different career options, but really wants to contribute and give back to the community. It's reframing and shaping that access. So with that in mind, how we get to $1 billion. One, we've got to strategically grow our patient volume and the lives we touch. And that means, again, being very intentional about leveraging data, leveraging technology to be able to understand who our patients and clients are across our different clinical sites, to inform how we reach out to them. We retain them, but then we also attract them to get them to know we do have high quality affirming services here. Utilizing data to better inform the types of services we provide to be able to meet the needs of our communities. Again, we're not a hospital or tertiary care facility, but we are forming and reaffirming partnerships with other hospitals and entities so that if you are a patient of ours, we may not provide that subspecialty service or that hospital service, but we've got strategic partnerships and alignments to be able to have seamless transitions into those services to meet the needs of our patients. It means thinking about other pieces of the business where we can be involved. So for example, retooling our research practice so that we're part of the innovation pipeline and the incubation pipeline of new ideas as we move forward in the future. Those are the kinds of things that attract foundations and other entities to want to partner and support programs that you're doing. As you build those things out, and again, firm up that reputation that you are a place of high quality care that is fully integrated into that larger healthcare ecosystem, people will start to see you as a viable option. They'll want to come and be a patient in your enterprise. And that grows that patient volume, that grows that visit volume. It also creates a space where you're nimble in terms of securing good deals on reimbursement rates for different practices. I'm sure this is probably not a surprise to folks. Reimbursement rates for certain services like dental services and behavioral health services, while they are significantly needed, are really low. And so how do we, continue to be a player in that space as well, to be able to inform policy that creates opportunities to support reimbursement rates that make offering those services that, again, we know are much needed, available to the community.
Yeah. Well said. Well said, Travis. I'm gonna share a question here that Geraldine had. One, she misses you in the DMV, and admires
Come
your
on
commitment.
out to Chicago. We'll take you out.
Indeed. She says, I truly admire your commitment to community health and underserved populations. With your diverse background, training, and experience, what is it that keeps you in the public health, community health space? What continues to drive your passion every single day, even when it's not easy with health policy and the financial challenges that you started talking about a bit earlier?
Thank you for the great question. You know, I was actually having a conversation. I had to chastise some employees on this the other day. I just fundamentally refuse to believe and accept that any entity that is public related, whether it's a health department clinic, a health department program, an FQHC, I refuse to accept that that has to be a place of subpar care, subpar treatment, and subpar access. One of the stories that I tell is so we've got 7 clinics across Chicago. So those who are not familiar with Chicago, we've got 3 sides and a lake. We got the north side, the west side, the south side, and Lake Michigan is our east side. Historically, north side, north of downtown, from an economic perspective, higher income, higher tax rate, higher income available for schools, those kinds of things, higher percentage access to healthcare services, higher life expectancy, etc. When you start to move in other parts of the city, you start to see more profound gaps in some of those outcomes. So, for example, 4 of our clinics are technically located in the north side. They're in different parts of the north side. Our new building that I referenced on Halsted and Lakeview area, the life expectancy is in the mid-80s. If I leave my office there and go to our 63rd Street clinic in Inglewood, which is kind of on the southwest side of the city, it's probably closer to the south side. Anybody from Chicago, I don't want to misspeak because folks are territorial when it comes to southwest side. But Inglewood has a life expectancy in the low 60s. If traffic is good, I can get from that one office to the other one in less than 20 minutes. I fundamentally refuse to believe that it is okay to have your zip code be in such close proximity to each other, but have that profound of an impact on your life. And the challenge is when we see neighborhoods like Inglewood and some of the other areas where we see lowest life expectancy, we're like, oh, they got access to an FQHC, or oh, we'll put up a health department system there. And it is substandard. The buildings aren't nice to go into. It's not attractive. It's just, and you don't have access to the highest level of technology, et cetera. I want to change that. And whether it means, going back to that strategy of getting foundation money, increasing private insurance, all those things, I want us to build a system that connects the dots, because again, a 20-minute ride should not mean a 20+ year difference in life expectancy. And what also adds to it is, unfortunately, when we're talking about the people who are dying prematurely, they look like us. I mean, I'm leaning into it. My niece, who's in college, tells me all the time, Uncle Travis, you are a middle-aged man. I am. And that takes on added significance because I'm seeing a lot of folks in my age cohort dying prematurely. Heart attacks, undetected cancers, strokes, things that having access to a good primary care provider would change. So, long answer to your question, but that's what motivates me and keeps me going. And as long as I have the opportunity and space in the room to have those conversations, I will continue to push that agenda and push the funders, push the providers, because we just fundamentally have to do better.
Well said. Well said, Travis. I had one follow-up question to that, and I would encourage other folks to ask questions as we wrap up our time with Travis here. You've touched so many different things throughout your career. You've been on the research side. You've taught. You've been a provider and a clinician. You've been on the startup side, you've been on the public health side, and now you're leading this effort. In the amazing words that you just shared, it seems obvious why you're passionate about doing this. What about the opportunity when it came up? Of all the things you could have done and all the things you have done, made you think that the same decisions that we're talking about, that people who have great resumes and great pedigree and great institutions, you chose to come lead this as opposed to any other health system or public health organization you could have led. What influenced that decision? I know the passion that you just shared is a big part of that, but yeah, I'm just curious to know that there will be other people who are in that spot having to make decisions for themselves, and wherever that calculus lands for them is wherever it will be. How did you think about it and weighing the opportunity cost of other things that you could have done?
Sure. Well, one thing I will say, and then this was not my motivation, but I want to make sure that folks understand, depending upon the FQHC or the nonprofit, sometimes the salary and financial benefits exceed those of some of those larger institutions. So that's something to also think about as well, that just because it is an FQHC or a nonprofit doesn't mean the financial compensation wouldn't be on par with some of those other places. So that's just something to think about that I don't think a lot of people realize. That has changed over the years. And also that's my way of potentially recruiting people if you're interested for Howard Brown. So as it relates to Howard Brown, part of it is moving towards again, I'm not trying to retire anytime soon. It would be great if I could in the next 5 to 7 years, but also being very thoughtful about what would my legacy be. And as I move into, later stages of career, what is it really that excites me and what fulfills me? And I kept coming back to when I was working at Hazel. I was working remotely, so I moved back to Chicago and spent a lot of time on planes, flying to different places. But it kept coming back to, how am I contributing to the community I live in? What am I, I'm a part of national meetings, national groups, but what am I actually doing to change and affect the communities that I'm living in and that I'm a part of? And when I actually was originally approached about the job from the search committee, I was like, here's some names of folks. I'm good. I'm not trying to get into that space. Particularly at the time, the election had not happened. So it was like, I'm not really sure how this is going to go down. But I kept coming back to, how am I giving back to the community that I live in? And then the election happened, and that added even more significance of, how am I utilizing those different experiences and skill sets to at least be a voice in the room for those conversations when we're talking about how policies are put together, how decisions or healthcare decisions are being made, that are influencing, again, the communities that I'm a part of, that are being hit hardest, who are dying prematurely, disproportionately carrying the burden of new HIV cases, disproportionately carrying the burden of maternal mortality, disproportionately not having access to healthcare. And after being moved in that space, I will tell you quite honestly, my faith is what tilted, and the corner was like, yeah, you got to go over here. As a person of faith, and praying on it, Lord was like, yeah, this is not going to be easy. It is not going to be smooth, but it gave me that belief and firmed up that belief of needing to help fix and run an agency that was designed to help people like me, who love like me, who look like me, who live where I live, and at least give it a shot. And I've also thankfully reached a point in life and career to say, if it doesn't work out, we tried. There are other opportunities out there, but I think we do have a really good opportunity to really truly move the needle and start closing that gap, that 20-minute gap of life expectancy that's also 25 years.
Wow. Well said. Well, Travis, we will continue to cheer on and support as much as we can in helping you shrink that gap, and excited to see what Howard Brown Health does over the next few years under your tenure. And please keep us updated on how
I was absolutely
support and continue to do that. And more directly, perhaps we should have a conversation about what we can do to get more Ron Brown folks working at Howard Brown Health.
We should have that conversation. Absolutely. I just want to also thank you for continuing to drive these conversations that we're having and bringing together folks. It's meaningful, it's impactful, and just thankful for the opportunity to be a part of it.
Yeah, absolutely, Travis. Thank you. What's the best way for people to reach you? Perhaps on LinkedIn or
LinkedIn's probably the best. And that way we can connect on LinkedIn because if you send it to the work email, depending upon the day, it may get buried and not seen. So yeah, feel free to reach out LinkedIn and we can connect there. Send me a message. Anybody who's a part of the Ron Brown family is truly a part of the family. And if I can do anything to help, let me know. And if I can't figure it out, I may know somebody who can. And something I want to encourage folks, particularly folks who may be on the younger end, don't be afraid to reach out and say, hey, I've got an idea or I'm thinking about doing this. One of my personal favorite people and favorite mentors I met through Ron Brown almost 30 years ago, Dr. Vivian Penn. And we met at one of the all, I can't remember the name of the, All for One. Anyway, one of the large RBS conferences years ago, and she's been a mentor of mine and friend of mine since then. And anytime I'm thinking of a new job, I reach out and have conversation and get her input. And then also just catch up as human beings because it's important to also stay grounded and connected with folks in that way. So don't be afraid to reach out. Keep up the great work. Keep doing big things. As I said, when I retire, I can look at all the Ron Browns doing great stuff and hope you invite me back as a consultant or a speaker from the beach.
that sounds great. Yeah, next time we'll make sure that you're by the water. Awesome, Travis. Thank you so much. And this was a perfect cap to an amazing afternoon that we've had. Feel free to log off whenever you're ready. I'll just have some closing remarks for our audience, and then thank you so much. And go Duke tomorrow in the game for sure. Man, what an afternoon. This and fantastic. Thank you to all of you all who attended, who helped promote the event. For those who are still here, who were speakers of the event and have stuck around. There's so much work that needs to be done, but I always walk away from days like this feeling like we've got a really good shot to win. And win can be defined by closing the gaps. Win can be defined by growing, and winning can be defined by getting more clarity on where you fit in this system. And so my hope is that these forums where we bring together alumni who are doing amazing things in a variety of fields will be helpful to you as you can figure out how you will join them in the effort one day. And so thank you all so much for being a part of this. So we did a version of this related to artificial intelligence in the fall. Today we did healthcare. In April, we're going to do one about life sciences. And there will be some overlap in terms of healthcare, in the natural overlap that healthcare and life sciences has. And so I wanted to make sure to emphasize that, and for folks here to be on the lookout for details about that event in late April. That'll be very similar in format to this. We will bring alumni who are scientists or who work with scientists. Some of them will have clinical backgrounds. Many of them won't, and it'll be more science heavy, but are committed to making sure that we understand our biology and chemistry to have all of the breakthroughs that we need to make a lot of the things that we talked about today in healthcare even possible. And so as you think about scientists or engineers or researchers, keep an eye out for the Life Sciences Summit that will try to capture a similar spirit that we did today and that we did with AI in the fall. And then we're going to continue doing these throughout the year too. One that's starting to come together for the summer is one that's in education, and that there are certainly educators among our alumni base. There are a lot of folks leveraging technology to close gaps in education. There are a lot of folks who have been in political positions of leadership, philanthropic positions of leadership related to education. And so over time, we'll try to touch all of these issues that every Ron Brown scholar cares about. And my hope is that even though we can't all be an expert and all dedicate our careers to addressing issues in all of these domains, that we can use and leverage each other to learn a bit more, to be a bit more informed, or to know who to look to for expertise in all of these areas. So thank you all so much for being a part of this. My hope is that you will use me as a vehicle to reach either our speakers or each other who have attended. Anytime that you want to connect with anybody else in the network, feel free to reach out to me. And if I can help you do that, feel free to do so. And yeah, we'll wrap here. More details about the recording that I would love for folks to share out for people who may not have been able to attend the event live, and certainly to rewatch some of the talks. Keep an eye out for that link too, so that you can share with more people that now that we're at the end that you think should have been a part of these conversations. And then most importantly, I hope to see a lot of folks next month. Next month, we'll be having our amazing gala and selection weekend in DC, as we always do, welcoming a new class of Ron Brown scholars into the family. And so if you haven't registered for that event, I highly encourage you to do so. And looking forward to seeing as many of my fellow alumni in DC as we can. So thank y'all so much for being here. Hope you have a great rest of your Friday and your weekend. Enjoy the Duke Carolina game tomorrow. Enjoy the Super Bowl on Sunday. I'm going to enjoy the first weekend of Black History Month too. And my hope is that this was a great way to kick off celebrating this month more broadly. So thank y'all for being here, and we'll talk soon. See you next time.